Muy buenos días a todos los que nos acompañan el día de hoy. Mi nombre es Guadalupe Zamora, coordinadora de la Biblioteca Virtual en Seguridad Social. A nombre de la Conferencia Interamericana de Seguridad Social y su órgano de docencia,
Juan Peniche is a medical surgeon by the medicine school of UNAM. He got a master's degree on medical attention, also by the same university. He got a PhD on organization and management in that same university. Dr. Dubon is certified by the Mexican Council of Legal and Forensic Medicine. She's a member of the Scholars of Management Sciences and the graduate degree in management from CONACYT and UNAM. She's also a scholar in the master's degree of health and management from UNAM. She's head of the Mexican Academy of Surgery and member of the Mexican Academy for Bioethics. Doctor worked as a medical expert in the National Commission of Medical Arbitrage from 1996 to 2009 and is president of the Arbitrage Room from 2009 to 2016. And like you know, doctor is a teacher here at the Inter-American Center for Studies on Social Security. But before I pass the floor to her, I'd like to remind you that we don't have a Q&A session. However, all your questions will be solved through our platform. And without further ado, I'd like to welcome to Dr. Dubon, who will coordinate this fourth session of the seminar. Go ahead, Doctor, the floor is yours. Thank you very much for your kind introduction. Good morning. It is my genuine pleasure being with you. As teacher of this group, I would like to welcome you, as well as thanking Dr. Daisy Corrales, Director of CS, for her invitation to participate in such an important seminar, Top Management in Social Security Institutions. And also for a good performance of the work team, especially Dr. Irma Juarez and Mr. Luis Pineda for their valuable contribution to put together this teaching learning module from the academic standpoint and from the standpoint of whole technological platform. So it's an honor to coordinating today's work that will allow us to share experiences amongst the countries in the region, speaking about current trends, quality in health institutions. And to start talking about this subject matters, I would like to tell you that we have international panel members. That's why I would like to to invite you to make the most of the experience and knowledge that they're about to vest upon you. The program that we've prepared for you today is made up by two blocks. On the first, we'll talk about relevant aspects on quality and attention to beneficiaries Social Security. And we'll have some feedback of our fourth module, which is devoted to quality in care. In the second block, we'll have the participation of distinguished students from the diploma course present their excellent work based on the impact in terms of health service rendering. So just a little bit of housekeeping. Please remain your microphones muted. There won't be question and answer sessions, but we will provide answer to all your questions. So all the panel members might deliver their presentations in an agile fashion. So to begin, I'd like to introduce Dr. Miguel Ángel Serrano Barrones. He is our first panel member. Dr. Serrano Barrones, doctor in top management from Centro de Posgrado del Estado de Mexico. So master's degree in management by UNAM and a master's degree in population health by the same university. He has a diploma course in management and financial direction of hospitals by UNAM, as well as postgraduate studies in gynecology and obstetrician sciences. He's a member of the Mexican Academy of Surgery. He has certifications and recertifications by the Mexican Council of OBGYNs. He's an associate professor of the Mexican Council of OBGYNs with a dynamic trajectory as a physician and teacher in the OBGYN field. Under the director of the OBGYN Hospital number 4, Dr. Luis Castelazo Ayala of AIMS from 2009 to date. And he's also been a part of teaching activities and courses abroad. So would like to thank for Dr. Serrano's participation. The floor is yours. Thank you very much. Thank you very much for a kind invitation from CS, very particularly Dr. Maria del Carmen de Bompeniche. Thank you very much for the invitation and the cooperation. And it is my pleasure being here with you today, sharing these passionate topics regarding quality. So without further ado, due to our time constraints, I will start with today's session. So talking about quality, just talking about doing things right, talking about doing things, first time around with excellence. But health is even more important because here we're talking about us working with human lives. We'll see some analogies during the course of this presentation, and well, this quality area doesn't necessarily start with health. Well, they started incorporating until we arrived to models, standards that we need to be constantly working on in the health sector. Next slide. So the content for today's presentation. I will try and develop these 10 items. And this is just some sort of framework for us to define today's session, today's talk. Next slide, please. Okay, so security culture needs to be within a framework. It needs to be foreseen in some sort of area that allows for its execution. And for that purpose, we've come up with this model of quality management. And well, I might be showing you this model of quality management, which pertains to IMSS institution. It doesn't really change of what happens within our health standards in Mexico through the Ministry of Health. This is a very similar model. Maybe some terms might change. However, as you can plainly see in the center, in the core of a model, you find persons, you find people, right holders. In models, this has changed um, to include communication. However, there are other areas like leadership until we arrive to this area called results for well-being. And as you can plainly see in this picture, and I will elaborate further on this, is the area of attention to right holders, human resources or effective human resources department that we need to get this communication and for us to have a satisfactory experience with the user and thus the service renderer. Talking about an efficient operation. And well, that's the way this model operates. It is a circle that allows to be as complete as possible. And to be able to talk about quality, we need to start by a principle, by talking about a principle. And this is an emblematic phrase, thou shalt do no harm. It's been around for a long time, from times of Hippocrates. So this means that person trying to help others when it comes to health, what that person had to promote was avoiding making things worse, worsening things, worsening ailments or diseases. But right now, it's clear to me that this Hippocratic phrase has been maintained throughout time. There's other currents of thought that have been trying to modify it a little bit because, I mean, around the execution of medicine, we know that many times this phrase was not that relevant, sometimes because of lack of knowledge. Some sort of maneuver might have been tried and executed, not to real will, but some sort of complications might have been brought about. So there will be liability by the person trying to contribute or trying to make it to do a kindness. So I mean, this might be a basic principle, but again, in this environment, some things might have been modified, and I will comment on this in just a while. Next slide, please. So to be able to see where we're at right now, we need to go to numbers, to hard facts, something that allows to be very practical, very pragmatic in this sense. So, well, let's see what the WHO has to say. 1 out of 10 patients suffer some sort of damage, some sort of yes, damage when receiving medical attention, some sort of harm. Moving on with numbers, I brought some highlights. So let's take a look at these hard facts. In some third world countries, 4% syringes and needles are reused. And well, here they're talking about certain sterilization process. So this 1 of every 10 patients might start getting complications, and we know that in the health environment, there will be the factor of infection. Now for 2007, and based on WHO, they released this solutions for patient safety initiative. And we also need to talk about tangible things that we have in our country. Maybe some neighboring countries share similar numbers. And here it says that 8% of hospitalized patients suffer some sort of harm. So that 1 out of 10 changes a little bit. And being a little bit rough in terms of some facts, 2% of some of these patients die. So obviously we need to reflect on how it is that we're doing, how are we contributing, because we know that a large majority of our right holders, of our patients that we're taking in the institution are state workers. And well, that they're like in a reproductive time of their lives. So we're talking about mean average of 18 once they're adults, and until they reach around 60 years of age, because of some standard that we have in terms of pensions and retirement. So in this, we have people who are obviously productive to 100%. So we also see that 62% of these events that happen within our medical units can be preventable. Can be prevented. So what can we do? I mean, this is nothing new. This might have taken different course as of year 2002. These areas of quality improvement, this friendly hospitals to right holders, to patients. So, well, we started growing the health sector, thus bringing about more solid and consistent proposals to do a better job. So again, I already showed you some hard facts in third world countries. Being a first world country, that doesn't mean that you won't have this problem. So again, some numbers between the year 2002 2008 only in the United States, between 200 and 400 440,000 people died due to medical negligence being the third cause of death. So this is not as exclusive as one might think. We could probably say, well, we have some scarcity, some limitation in terms of human resources, financial resources, even infrastructure and whatnot. And we know, this aspect of health and patient attention happens throughout the world. There are, of course, factors for health deteriorations, and many times this ends up with the patient dying. Next slide, please. So, going a bit more into statistics, I can show you the case of 2013 in the United States. And making comments about this information about cause of death, medical errors could be found within the three first cause of death. So imagine only surpassed by heart diseases and cancer. So this medical mistakes and some chronic respiratory ailments, and well, this of course information from last year before the pandemic, and of course these numbers are different right now. And we have another item, number 5, which is accidents. But of course, it's really concerning what's going on, especially when it comes to medical mistakes. Next slide, please. So what is it that we have to do? We need to bring about culture, patient safety. So this production of group and individual values, we need to generate, we need to be fostering them. And well, of course, education starts or begins at home. We need to take into consideration these small details. We need to work based on them and fostering this. And obviously, talking with families and all the population that devote our time to public health. And that's why we need to start changing perception. We need to start changing the frequency of reported events, things that might be happening in our own medical units. And well, to provide a general degree of safety for patients, and try to convince our patient for them to participate with us, for us to take care of this aspect. Now, for us to be able to achieve this culture, we need to develop certain values. Like I mentioned, some have to do with education, coming from home, from first care, probably not leaving small children, toddlers, starting to walk unattended, um, safeguarding pretty much, or child-proofing homes, not living with floors, the things like that, things that might seem irrelevant within the household. We need to really take care of everything pertaining to safety, health, and integrity. And we can start generating these small values as an internal responsibility, being able to care of myself or taking care of my family. So this brings about more interest when it comes to uh, medical service rendering institutions. So we need to be very, kind and cordial as much as possible. And we also need to work in these interpersonal relationships in us looking to improve, because we're constantly looking for right holders to have that sense of interpersonal confidence, trust, that well, they know they can count on all of us, from janitorial staff, from nutrition area, and everything that has to do with logistics also, or when even working in dynamic at a clinic or at a hospital. So talking about this process of security culture, that means that I have to be proactive, but this carries some sort of maturity process. And we could start in this first level called pathologic. might seem that this situation is just a problem, and at this level, people might think, why I have to report this, or I don't know, I might be concerned because of some sort of administrative penalty, because my boss, aside from scolding me, obviously, thinking, well, my patient under my care, he fell, he probably, I don't know, slipped because not being able to really hang on to a banister. I mean, aside from obviously scolding me, the patient himself or herself will end up hopefully only with the bruise and not with a fracture or a larger harm. But we need to start advancing this thing that has to do with the culture of safety. So we should go beyond just thinking, oh, this is somebody who's going to shout at me or scold me, or give me some sort of penalty, some sort of fine or punishment. We know this is hard, it is complex. We know the different processes in which all healthcare staff is involved at all times in hospital life, because I mean they were working on AMIT stuff. They need to charge patients, doing paperwork. Maybe while they're doing that, the patient goes to the bathroom, patient sleeps, or he's left a tray of food. Maybe that person trips or the patient trips. So again, there's a myriad of situations in which the patient might be involved in. So we need to be alert. We need to be attentive of all this, because at some point in time, this might things happen. Things do happen. Well, we need to have the culture. Being honest, explain what happened, and face any liabilities. Next slide. That's why we need to start with acknowledging the existence of this risk in different activities pertaining to the organizations, sometimes even janitorial staff from different shifts might might bring about the situations. Maybe they leave a wet rag here or there, or they forget to be the small stools next to the patient's bed, and the patient tries to get up the bed, the patient sleeps, falls. So yeah, I mean that person needs to think and say, yeah, it was my fault. I should have tried this area, or I just forgot to do this or that. But again, we should try to always do things correctly, and writing mistake reports. So we need to find how is it that I can control the situations, because we will try to avoid situations, but we cannot prevent them 100%. So we'll try to at least decrease situations. So the idea is for all the staff having this culture. Next slide. So I told you that this idea of quality didn't necessarily start with environment, health area, but we started incorporating it. And an analogy, the automotive industry. These are very simplistic aspects, like using the car safety belt. Like present industry back in 1984 had these great luxury cars, but none of them came with a safety belt. They didn't even have a headrest to mitigate any crash and collision. And, well, even more importantly, this didn't come equipped with safety belts. Because, well, I mean, these cars, the seats were luxury. They were velvet. The upholstery was velvet and whatnot, very luxurious, or leather. However, a company started started incorporating seat belts. We're talking about 1956, and as an option within these things like improvement, looking for safety in case there was some accident. We understand that back then there were many cars, and the speed of circulation didn't exist as now. Things parameters of around 50, 60 kilometers per hour.
Next, please. And there's sometimes when we had to increase the speed, and obviously it was complicated. However, the design of something that's so simple. I mean, the seatbelt. There's 3 points there with the seatbelt. If we analyze it, I mean, to this day, it's still something that we use. I mean, however, it wasn't like a law or used in all countries. I mean, there's multiple factors to consider here. What happened in Mexico in 1997? I mean, somebody thought of it. They thought it up. And after analyzing it and analyzing all the elements about how to improve the safety of the user while driving, I mean, how could we benefit the driver? Sometimes we need a process, and the process could take time, could be long. We know that it's effective. It's proven that there's a decline to reduce like a major incident or accident that could take someone's life. So those are those steps that we have to take forward. However, those steps take time. It's part of the process, to mature the process. So we want to be improving on a day-to-day basis and apply this in a hospital setting. This has to happen in parallel with a major support of laws and regulations. Obviously, it should be backed up with regulations, acts, and the bodies involved, which are in charge of it, like the council or the general health committee there. So we're talking about what we know as like they're like essential. So we're all in that search. We're trying to search and improve and take preventive action, in health. But next slide, please. Well, and the job of all this team generated like the materialization of it. I mean, here we have like the documentation that regulates and but next slide, please. We're going to be talking about the essential actions in each institute or establishment there. I mean, we have to take care of the safety of our patients during all the process. I mean, we have 2, 3 levels of attention, but there's many elements of the patient safety that we have to consider in a clinic. There's a hospital. We have the hospitals, third level hospitals, with a lot of sophisticated processes in a hospital setting. But maybe in that clinic they have nuclear medicine and other disciplines, but there's special care for the patient. So as you can see in your slide, there's 8 international goals or actions, essential actions that are very specific. And surrounding these essential actions, we have to think about the adverse or negative scenarios that could also arise in the context of the healthcare environment in a clinic. Next slide. Here we're going to begin with number 1. Next slide. The basic elements are first we have to get the general data or identification of the patient and improve our processes. So at least we have to be capable of obtaining the general data of the patient, name, birth of date, before we like wrongfully attend like give a service to a person that the service might be wrong, but that's why we have to get that. So before, if there's 2 or 3 people that have like the same last name or even maybe the same name, and if we're colder or we know if we analyze this, you know, in an objective way, we have to think about patients who are in ward one, being like bed two. And then if you are going to give a patient that's in bed four or something, and you give it to the other patient in bed eight or bed one, so we can get like lost along the way with the patient, and we might not take proper care of the person. So that's why it's so important to take care of that. First, I mean, it sounds simple. I mean, to obtain the identifications or of the patient or the general data of him or her, but okay, maybe a person in the hospital can identify one patient, but we know that with open communication, it's important. That's very important. If the patient was suffering a condition, sometimes the patients can't verbally express their general information or personal data, or maybe they have a chronic disease that doesn't enable them to do this. You know, if you have a patient there and you move the patient after a few days of being there, and you have to, I mean, if you know, sometimes if you move people around in a hospital, you might forget like their name or even last name, or even, you know, there's so many situations that could take place or happen there. What we want is to generate a standard and take care of our people. I mean, wherever the patient is in, maybe they're in a unit or ward, or maybe there's patients that are waiting for their surgery. I mean, instead of just assigning a number to the patient in the patient's bed, like patient in bed 22, you can give them the number plus the name and last name of the person. So that is how, I mean, but anyway, we have to be capable of identifying the patients with bracelets on the wrist. We have to take care of them the best way possible. Next slide, please. Here, as part of the process, we need to, as I told you, identify the patient. We have to be very careful with this. Sometimes, I mean, you can't just be confused when you're obtaining this data, but maybe, I mean, we have to think about the situations that could take place. There's specific medications that have to be administered. Maybe if there's a plasma or blood transfusion, that there's situations that have a collateral reaction in the person's organism. If I have a specific blood type, and sometimes maybe the neighbor in the next bed or in the next bed has was there, and maybe the other physician that's taking care of these people got confused with the patient that's at the right or left. Sometimes there can be complex situations that happen in these places. Like there's situations when you have to transfer a patient to another unit for a CAT scan or an MRI, then so instead of taking the patient from bed 25, they might have done something else. So we don't want those situations happening. Like if you had like a patient in the COVID area, you had a patient that's in the plastic bag, and then you have to think that patient, did we move the patient from one place to another? Did we? And all of these things happen. So next slide. Sometimes not everything we see is real, right? We can see in this slide, this picture, you can imagine so many things by looking at it. Here I can observe this picture from my understanding, or my perspective, that's different to the perception of somebody else, or the even the family can see things differently. What I have to do is to have that effective communication. Well, with this effective communication, I have to do things right, timely, and thorough. Be thorough about it and follow the processes that I have to follow with a patient to know that we have to listen, we have to be capable of writing and reading and confirming the identification of the patient, rewrite it, and verify, validate. So sometimes there's many people involved in this process of obtaining this information. We're people and we are human, so we can commit mistakes. Obviously, when there's staff, when there's more aides involved that help us throughout the process, we could try to control, you know, or avoid committing mistakes most of the times. But we have to be very aware about what happens when there's a change of shift in a hospital there. But happens, there's a change of shift, and then there's an urgent case in the next bed or cubicle, then you have to leave things there. There's an urgent matter in the other cubicle, and maybe some people, we tend to be careless sometimes, and maybe, I mean, you don't follow the steps of your activities systematically. So we are always trying to do things right, use the tools that we have or anything that can help us, like sire. Okay, we need to be capable of doing what's right when there's an incident and go through the proper patient assessment. Here, we have the capacity to control, I could have verbal control with my work team at all times, because sometimes if I have a lead to be a leader and we're trying to resuscitate the patient, it's like, and you tell the rest of the team, give me 2 milligrams or this medication, or somehow, I mean, there could be other situations taking place. So we have to take of all the elements that take place, or the situations that take place when we're taking care of a patient at a specific time. Obviously, this is just an example. What's happening with a patient? That's a situation. Okay, you have to obtain the patient's name. You have to see if they're breathing. Maybe the patient is in the post surgery area, and after that surgery, they have to be observed. Uh, you see what are his, how he's doing. So then you can submit your recommendation or find the right people to do what they need to do at the right time. And in this, I mean, sometimes in these places, what happens? Communication. And then we have sometimes, for example, the handwriting or the doctors or personnel seems to be easy to read, but sometimes it's not easy to read. When someone tries to read something that's been given to them, it's like you can't just interpret someone's handwriting. So we've tried to follow our guidelines, so certain guidelines. So we have to be very clear with the data, specifying the dose for the patient. If there's a comma, if the dose is going to be in milliliters, milligrams, we have to know the time interval of in which we'd have to supply this to the patient. And sometimes you have to be specify. And if you write and somebody's handwriting might not be easy to read, and things could change just with a comma or period. But if you have to transcribe or rewrite it somehow, we do it, and that could could lead us to better results. Next slide. And I mean, the aspects or the data that we have as reference for the patient, all the data of reference has to be very clear. A 52-year-old patient is not similar to a 25-year-old patient, so we need to know also who's doing what and when We have to be very precise when identifying the patient and following instructions or indications. Next, you see, this is like these threads that are all tangled up in the image, obviously. On one side things can be very clear and the other side not. So if it's clear, there should be no complexities. The next slide, please. Next. This is um, like security in the process. I know I'm running out of time, but we have here a list of the processes. I mean, when we buy something, store it, and all the process takes place, and it's a lengthy one. Okay, if we have to go through procurement of certain products, you have the codes there, but we have to be very careful. You see, some constituents are similar. We have to think about the percentages as well. Or can identify by looking at the data and understand it faster. And the environmental conditions in a lab obviously could allow us to eliminate risk as much as possible. Next, we spoke about what is like a prescription, like medication. Sometimes, I mean, think about it. I mean, sometimes we don't, if we give somebody a prescription and you write it that they have to take the medication every 6 hours or hours, and there could be some complications. Okay, so next slide. Okay, if we have to transcribe the data, it's like if the person, the doctor that's responsible for the person doesn't understand what's been written, then we have to think about how to properly use what's being prescribed or ordered. Now, here, there could be, okay, we can obtain the data of the medication and mark the medication so we don't lose the data of the patient and along with the data of dose. Here, we're in the segment of, next slide. As I told you, there's so many elements to take care of. We have to be careful with the medications. Like these have to be written correctly so they could. The names of these medications, dogoxina and dorixina, are very similar, but we have to be careful with and verify what we're going to give twice. And here, if there's a situation happening, I have to be in compliance with ethics. Next slide. Here, sometimes you see there could be long lists. You have to be very specific in the list and give that to the patient so they understand what's being given to them. Next slide. It's about procedures here in this next slide. Here, it's procedures, and we know what's happening when, I mean, it's if you're gonna have surgery or eye surgery, it's not the same to get a surgery in your right or left eye or left feet or right foot or right foot and left foot. There's differences, so it's not all evident. If you go to the dentist and you're gonna get one of your teeth removed, I mean, or extracted, like you have to extract the right tooth, not the wrong tooth. I mean, you have to be very aware of it. And so many situations can take place because the patients might be sitting there in the procedure and suddenly there's a like blood loss because of hemorrhage or something. And suddenly the I mean, we might get lose our focus. Or, so then that's why we have to constantly verify what's happening. We have to be very careful when you're gonna cut the patient or get the patient prepared and ready. These are some of the protocols that exist. These are checklists. Here, I mean, there's timeouts, and during these timeouts I can ask, like, for to brief the team so they can confirm during the briefing what's going to happen with a patient, if what we're going to do, the process is the right process. And next slide, please. Here, the reduction of infection is this point. Right now, due to what's happening now, we know that there's the Codecin, there's some committees that analyze what's happening with certain associated infections. Here, in a hospital setting, we have certain diseases and we try to control that. But amidst the pandemic, there's there's a lot happening. There's 5 moments which are fundamental for us. Before we take care of a patient or have direct contact with a patient, there's 5 moments or process that are important. We have to study the patient and then go to the next patient, but follow these steps and the guidelines, like like washing hands. And there's a major process also, but we have to be very systematic about it. And I was talking to you about the reduction of risk. I mean, we don't want our patients to suffer any damage. There's patients that we have to deal with at different moments, and when we're working with them and there's a shift change or the prescription's going to be modified, is the patient conscious or unconscious? We have to see what the situation of the person is, and things might change. The condition of the patient will change. So next slide. Depending on the situation, there's certain constraints. We have to analyze the patient's limitations, mental state, or and the treatments, and we have to maintain all of this well identified. And here we should always be careful with our patients. There's patients that have some risks, so we have to be aware of them, like adverse events or negative events. I mean, there we have a log of these. If there's incidents that happen, I mean, they're in record. So maybe a patient suffering a complication and their health is affected, or the patient dies. So we have to be very clear, precise, and always work under ethical conditions. We have to be capable of verbalizing this to their relatives if they've passed away, and the administration and all the process that follows in a situation of this nature. So we have to have clear about what are we going to do with the proper intention, as well as the team we work with. Next slide. Here, there's negative or adverse events. I mean, here we have to manage them. In 2018, in some state entities, we didn't receive in some state entities the full reports of these logs. It's maybe we lack staff. We don't have enough um, elements in our staff. We have these entities. However, there's like, and always, and we're having to interpret the whole situation, and we have to be capable of doing so. Next slide, please. Well, this the next point is the our security. That's part of our culture. We have to measure and be careful when measuring the data, and be careful with all the data so we can improve the attention we provide, because they're beneficiaries. Our patients are beneficiaries, and we have to be there as staff in the hospitals to control the whole situation. There's different ways or dimensions of going through an assessment of issues related to the patients, like safety there. Okay, next slide, please. Obviously, how do we use this assessment or evaluation protocols there? We had the participation of many state entities participating. There's these in this matrix of data you see in the slide, the the there's medical incidents, there's errors, there all the data is in this matrix there. There's but it requires for us to read this data, we need to obtain it and analyze it with maturity. There's also so so when we think about the surveys, we rolled out the surveys in 27 state entities in 197 hospitals, and the data has been submitted and seen now in the graph. You see the points about that we have in the plot. Next slide. Here you see in the slide, this means that there's change all the time there, and there's different shapes and sizes. Sometimes that change could be different. It's all different in that slide. You see the surrounding also changes, and that's the slide that they shown. Also, in aeronautics, in that sector, in aviation and mechanics, there's always certain standards. There's going to be checklists that have to be verified. If the aircraft has like two turbines or an engine, and they have to check that the supply of fuel, the efficiencies, they have to go through their checklist and check the aircraft so to make sure that everything's fine. So checking that, I mean, must be, if we have to verify this, we depend on the crew and we depend on a verification list or checklist. I mean, in aeronautics, that's a must here. That's also something that we implement in health. What's controversial? The difference. I mean, what could generate controversy is like the differences between what we perceive and what reality is. I mean, maybe if we see a patient and we might have a perception about the level of complexity that the patient's in, but maybe it's a different situation. Next slide. We know that what we do is not easy. This is from Robert Herzberg. And we know that what's difficult takes time and the impossible just takes a little bit more time. Right now, we're doing things right and in the first try. Thank you very much. Thank you very much, sir. Thank you for your excellent presentation, Dr. Serrano. Your concepts, your methods, and models or methodology all of this lets us think about how we're going to provide the proper attention. You've made mentioned who's the service provider, the patient, the identification of the patient, the many elements that we have to be knowledgeable about, that directors have to be very, very like just focused on them. We use the right tools in this field to work sustainably and meet the standards that we must meet in quality. Thank you, sir, for participating. Thank you for participating. Thank you for the invite. Now we have Juan Carlos Esquivel Sanchez, who's here with us from Costa Rica. He's going to be talking about the quality of the services that we provide to the beneficiary and on Social Security services. He's the General Director of the Strategic Center that safekeeps data on Social Security in his country from 2018 to date. Mr. Esquivel has worked in different disciplines as a physician, as a scholar. He's an administrator, a professor, and he works with international bodies with the Costa Rica and Social Security entity. He has also worked in first level, emergency levels, or ICU wards, and worked with HR of the CISS, that entity. And he's been also the leader of the postgrad or grad studies in Costa Rica. Then he was appointed as the executive director. Besides this, he's also a member of the steering committee of the Inter-American Center of CS and VP of the Technical Commission, which coordinates, innovates, and works for the international communities on social security matters. He has an MBA, Business Administration degree there in Healthcare Service Administration. He also studied in Barcelona. The floor is yours, sir. Mr. Juan Carlos Esquivel, please. Thank you very much for being present with us today.
Dr. Devon, good morning. Good morning to you, all my peers before me, panel members, and students. No, we've been together through this diploma course in top management. So again, I would like to thank Dr. Daisy Corrales Cias and the full team, Dr. Devon, Dr. Juarez, and all the cadre have guided us, accompanied us, invested. So it is my genuine pleasure having the chance to talk with my peers. And aside of being some sort of refresher of the courses that we had in this four module, now I would like to go back and see this from the point of view of institutions and the attention to the user, especially focusing on social security, Caja, IMSS, ISTE. All of us taking this module, all of us have under our care different functions in Costa Rica. Caja Seguro Social, out of its own constitution, has the function of rendering health services. We're the only institution that renders public health services in the country. And aside from that, we have pensions under our care. And together we're joined. I'm here. We're joined by peers from other national organizations like Junta de Pensiones del Magisterio Nacional in Costa Rica. So I would like to make this brief introduction to start talking about such a relevant subject matter. And I have seen this as some sort of a cascade of subjects. Of course, this diploma course is extremely well structured and designed, because we started out with evidence-based management, then directors' skills, and everything that we saw yesterday, organizational development, until we reached quality in service. And without a doubt, I think it's the best way all these subject matters when we're talking about top management of any institution. And we know that health services rendering is extremely important, and that's something that I would like to talk about here during my presentation. So I will start by sharing my screen. Okay, like I said before, subject matter of quality in institutions that we represent is vital, is of vital importance. I believe that all institutions in which we are, also workers, have different functions under our care, and it's really the search for what we want to have. And that's quality. That's the ultimate purpose I would like to have. So during presentation, we'll go over different elements that comprise them. We'll see how is it that we can work on certain plans a little bit in a general way. But we should start with these definitions of quality. Dr. Miguel Angel Serrano, during his presentation, talked about the safety, the security of patients, which we, of course, were including if we want to go to the if we want to achieve the ultimate quality. And here I'll talk about social security service and medical attention. So that quality has to do with the degree the services are rendered to the people and to the population, and the probability of having desired results in health subjects, results which are consistent to the knowledge of the medical professional. In this way, this can be extended to all services rendered by social security. This might be transversal. Of course, quality is something that we're constantly striving for a transversal across the board in all the services that we render. In the case of Caja Costarricense del Servicio Social, in terms of pension administration and health services. And the same goes for different organizations that we represent. According to WHO's quality service is the one that identifies the needs of health, whether educational, preventive, healing, maintenance of individuals and population in a total, precise way that devotes resources. And here we're talking about human technological resources in a timely and effective fashion as the state allows for. So we're living this global situation for a year now, and despite being with the pandemic, we've had to adequate or make flexible different areas of the health system to be able to tend to the pandemic. And all of this has in its core the quality component. So, I mean, the pandemic couldn't leave or set aside this topic of quality. What we had to do was to put ourselves in the context of this situation that we're living under the light of the processes and every single service that we provide with the best quality possible. And here I would like to make small comparison, because what I told you is that the aim that we're looking as health and social security institutions is arriving to this degree of quality. So we have elements, basic elements of quality, which are timeliness, professional competence, security, like the presenter before me mentioned, and ethics, which is extremely important and valuable, having everything pertaining to quality, and as well as satisfaction of expectations. Afterwards, we'll see how is it how when we talk about satisfaction, we need to satisfy our institutions to the inside and to the outside of our institution, those being our users. And we also have some philosophical principles that guide our acting, and this principle: universality, solidarity, mandatory, this being mandatory, unity, equality, and they're geared towards rendering of services of Caja, IMSS, ISTE, EMA, and all the institutions represented herein. So that's the goal, that's the purpose, and this is a subject matter that is very clear to all of us. I mean, those of us who have the chance of being directors of health centers, we know that that's the ultimate goal that we set out for ourselves, and that should be the main subject matter in many of the meetings with many of the people that report to us, is carrying out this very important functions, all of us with responsibility, but always keeping quality at the core. So this is important. Again, it's important to really take into consideration that we might see this as something transversal in our processes, irrespective of healthcare process. I mean, quality plan can be put together from different sides. You might have a quality plan in hazardous waste management, and also having quality in admissions. We talk about security in the patients when we're rendering our services, but before all that, we need to have really clear the concept that what we're looking for is keeping people at the core of everything. So our attention in quality needs to be geared towards people, because people will be ultimately using these services. And what are the characteristics of quality? There are many points of view, of course, all of them valid. And an example might be the continuity, bring continuity and attention, or in care, whatever we do to the inside of our social security institutions, and needs to be relevant, because this quality needs to be felt and seen at our level, our peers level, and in the institutions we work in. And again, this should be very important for people to perceive that quality. So this an extremely important characteristics of quality, and it needs to be lived in a systemic fashion every single day. You're supposed to live with quality at all moments. It needs to be acknowledged and respected. We should have a goal for ourselves, and these were all the departments making up different institutions that we represent here. There needs to be certain departments destined to that continuity, that look quality, that look for improvement, going beyond what we've achieved so far. That's why it's always very important to be setting goals for ourselves, be analyzing the different goals right now with the whole pandemic issues. Different functions have changed within institutions. That's why we need to rethink our goals, and well, work geared towards new functions that have been assigned to us, and that we ourselves have had to work on, or make shifts because of the pandemic. And finally, knowing and real placing value in the physical and time environment. So when I talk about physical and cultural environments, and even temporal environments, I go back to the skills that, yeah, the personnel in managerial positions should have. It's extremely important, and to be able to arrive the goal of the quality that we want to maintain, the quality of the social security benefits that we render. All these pillars are extremely important, and human resources and being able to develop these skills, all that stems from a selection process, as well as a training process, organizational development, organizational environment. This is an extremely important aspect in this development. So it might be true, quality per se has certain characteristics. There are many other determining factors around it, factors that help us maintain that quality whenever we render a service. And that these actions need to be well oriented that we have. So definitely all our actions should be geared towards quality. So what is it that we're really looking for? We're looking for attention to be based on people, having people at its core, for us to actually look for that efficiency in the processes under our care, for this to be safe, for the attention to be safe. I mean, whether there are beneficiaries or not, security will play an extremely important role in all our quality plans for different departments of the institutions under our care. Effectiveness, like I mentioned, that's part of improvement in efficiency and efficacy. And with the with the pandemic that we've been living for the past year, we have different challenges going to the future. And I'm talking about the near future. And this pandemic made us reach this future in just a couple of weeks. I mean, things like improving our attention models, like telemedicine. This was present in one way or the other in uh, in our health services, but it was not really rooted. It wasn't really. That's why we really had to start using it during the pandemic to be able to continue providing attention in other pathology, and to make refurbishments in different hospitals, in different health centers. We had an experience in Costa Rica, in Centro Nacional de Rehabilitación. We had to refurbish the whole hospital in a matter of weeks to turn it into a COVID hospital. And aside from that, in the other national and regional hospitals, where we had to refurbishment to be able to accommodate more beds. And what was the ultimate goal? Well, the adequate rendering of services to be able to bring in more patients. I would love to be able to provide medical care to all the population. Unfortunately, we were about to collapse in our system because of lack of hospital beds. From one week to the other, we had to implement all these actions to look for a way to deal with this. And inside all these actions, of course, quality was still at the core. So in terms of accessibility, there's a whole challenge for us. I already mentioned telemedicine. We had to the the uh, the pandemic and implement it in many specialties. We thought that this would not be a trend, that it wouldn't catch, but we did implement it, and it gave us great results in providing follow-up to the patient with other pathologies, and even coordinating moving the movement of patients from their homes to the hospital. So all these challenges we had to face, and we had to face them with best quality possible, and providing access to all members of the population who required our services. So we needed also to provide follow-up to other patients. Another great challenge that we have in terms of a health system. Other non-transmissible and non-transmissible diseases that require greater attention, obviously more budget for the organization, and that's where attention models should take into consideration all these challenges before us to implement measures that actually help in rendering these quality health services. So, of course, attention models in health. And primary attention models are very, very effective to be able to grant those benefits with quality in a timely fashion and with the most accessibility possible. Universality we're talking about in health services. And with that, we could save that cost of treating those chronic diseases. And what we can provide just palliative care or sometimes rehabilitation. And another challenge: human resources and technological resources, which is very very important and sometimes the driver of our social security institutions. I mean, well-trained human resources with the necessary competencies, skills, like we saw in this diploma course, we saw the different skills that people in directive positions need to have, but also people in the technical operational areas need to have different skill sets, different competencies. So that well, they can do their jobs in the best way possible. And we shouldn't even talk about technology because we're in this fourth industrial revolution, like many people have said, and that's because of the contribution of technology. And social security institutions haven't escaped this, but on the contrary, uh, it's been great for us to be able to implement new technological and digital system. Us at the Caja Costarricense de Seguro Social have made leap and bounds with digital log. We're using with different levels of attention, first, second, and third, all the way up to more specialized service and attention for benefit holders. So this is a system that's closely intercommunicated with the other levels. That's why a patient that arrives to a specialized hospital, eh, I mean, the procedures done to that person will remain in his file in case he needs to go to a different care level. The doctor will be able to see that person's file, a digital file. So anything that has happened with that patient in other levels. And of course, technological area has brought with it different challenges in many aspects. And I'm not only talking about rendering of health services, I'm focusing in other types of benefits, social security, pensions, for instance, in things like financing and collection. Even technology has been important. We need to analyze the challenges that we've had with the coming of technological applications. For instance, everything pertaining to food distribution has presented a challenge in itself because these are workers without employers in the country. This is an application they enroll to and they carry out a work. So these people during their work they might run into an accident, and that's where the dilemmas, institutional and financing dilemmas start with this type of benefits, because that company is not really contributing to social security. Many times workers do not have social security. So a challenge for financing and for collection in all social security institutions. I know that the Inter-American Conference on Social Security and also the International Association regards this as very important hot topics, which is food for thought for all institutions. How we're going to tackle these issues and providing accessibility to all these people, and at the same time providing this attention, these services with health. I mean, with quality. So now I will talk about this models a little bit. I will not spend a lot of time here because we already saw this in class. First, we start with the Ruelas and Coles model, then benchmarking, reengineering, and ISO 9000. These were some of the best known models. So there are other quality standards that have appeared in the international arena to collaborate in the look for that end, which is quality in social security institutions. So just to remind you that Ruelas and collaborators, their model, talk about different stages. One was monitoring, and monitoring has to do with providing follow-up to attention process, mainly geared towards medical area. So it starts with the monitoring, then an assessment or evaluation, then measuring of a process. That's why I told you that quality plans might be regarded from the processes that we have under us. Maybe a department has its own quality plan, then there's a general plan for a hospital, for a department of social security. Then comes design and organizational development. And well, this, of course, implicit in looking for quality in rendering the services. So then organizational changes have a relevant role, very important role in this. And we should always need to have them into account whenever we're producing these plans, when we strive towards quality in our services. There are many educational techniques that allow us to develop, like we saw yesterday in Professor Samudio's class, everything pertaining to organizational development, that might allow us to warranty that quality that we're looking to have in our processes. Benchmarking is extremely important, and here we need to make an assessment of competency or our neighbors. How is it that they're doing things in different health institutions? I mean, the same processes. So it's not to copy from each other and pretty much replicating the same thing, but we do need to have an understanding how the rest of the people are doing it, how your neighbor, quote unquote, is doing it. So we need to see what things we can put in practice to be able to establish this benchmarking model. For this, we definitely need to start planning, identifying, and we need to establish comparisons with other processes. We need to make a very in-depth analysis to see what's the performance gap in our institutions, in our departments we're currently working, where I'm trying to implement this quality plan. Afterwards comes integration. Here it's important to take into consideration communication that I have with my whole department, with my whole institution, to be able to set a benchmark that will allow me to develop that plan I want to implement in my department, in my institution. So again, for that, it's very important to achieve a certain degree of maturity to be able to have a leadership position, and to make sure that these practices and even benchmarking are integrated into all the process under me. And then comes re-engineering, which is another model that we saw together, and that's meant for the improvement of performance in your different departments. And this entails meaningful changes for us in the Caja Costarricense de Seguridad Social. At this point in time, we're subjected to a very relevant and strategic process, which is restructuring at the central level of our institution.
the administration and finances. I mean, so many tasks that are directly linked to administration of them. We need to analyze the best way to move, like in the entity in a near future. We need to meet the requirements. But what happens is that many times around, what happens is that there's sometimes resistance or negatives, but I do see that processes to achieve the quality that we have of our processes must implicitly somehow enable staff to communicate correctly, transparently, and there should be a message that really is rolled out to all the staff. So they are aids and working for the improvement of the processes. As I told you at the beginning, quality is something that we strive for constantly, that goal that we have as institutions, because we represent these social security entities. We want to achieve the level of quality that's required in the services that we offer. By re-engineering, we can do this in all the departments. We can do this in each department. So each department can have their own quality control plan. The ISO standard, the international standard 9000, is the standard that's known by the majority. I mean, it's like do as you say as you do, improve it, and prove it. So that's why this standard, the norm, this international standard is so important. The standard is our guiding document. There's the requirements for compliance. We improve our performance, how to audit ourselves. There's a standard of the process. This standard has been used a lot. It's been used in many companies. This standard is implemented in many entities that work for Social Security. This is why I want to tell you that besides the models that we've seen, I want to talk about the accreditations or the seals that are at the bottom of the slide. Those are accreditations that specify that we're achieving excellence when we're providing a service. That's why we're working to have quality services. Some, like norms we might know, like the EFQM, is a committee. It's been constituted in Europe. It's a seal, it's a stamp that proves quality, that gives you, you're under the accreditation. There's Health Choices International, Mission International, the Canadian accreditation entity. All of these bodies could issue a quality seal or accreditation because these are to be used in hospitals. This, I mean, Joint Commission International focuses on healthcare services, and they were very strong some years back. I'll tell you that back in 2011-13, Joint Commission International had a very important role with medical tourism, that well-being tourism. It was called like that way back then. So it happens that in the US is one of the countries for, I mean, medical tourism in our region and in the whole world. They have different models in different countries. Like in the US, there's Medicaid, there's other insurance companies. And that's when, back then, when insurance companies started observing that they could send their beneficiaries to have some procedures on them to institutions that did have the accreditations. So these seals or accreditations or standards prove quality of the procedures. We're talking about very specific processes like Health Choices International focuses not only on what's clinical, but also in the field of odontology. I mean, these are services that many people around the world look for. They're pondering costs, and the costs of these services are usually very high. These stamp seals or accreditations have become more relevant because they're quality control in our institutions. Our institutions should be under the accreditations. I mean, in the Mexican Institute of Social Security, I think that they have their own system for quality control. We're public entities. In Costa Rica, there's 3 hospitals that have these accreditations. There's 3 private hospitals in Costa Rica that have the accreditation of Joint Commission International, and then Health Choices International that focuses on the field of odontology or dentistry. I mean, you have them there. So, and the insurance companies are very important also in these themes, which are very important. There's a fine line, I mean, between what happens with insurance companies. There's insurance companies that will send abroad or that will stop sending abroad some of their beneficiaries to get a procedure. There's an insurance company in Germany that has contractual stipulations with specific resorts in Southeast Asia for these matters. So there's patients that need to go through a process of rehabilitation after suffering some trauma, and many of these services are provided in Thailand or Southeast Asia. So that rehab process is there. It's part of what the insurance company pay and their beneficiaries. So the companies involved with these or research involved with these processes like do have the accreditation with these seals or standards. You know, in our fight for meeting the standards, we have to know that it's always constant, and more so in public health care and healthcare services in general, whether they're private or even if the services are being provided by insurance entities. Now, if we speak about models that are a guarantee in the field of health, I mean, we're talking about having or meeting the standard that gives us the opportunity, that guarantees the access. I mean, these institutions are financially protected as well because of the guarantee, that health guarantee that they have. That's the reality. Now, what I want to talk about is I want to speak about the next topic in a very general way, in a broader scope. How could we draft our quality plans, our schemes for our institutions? I will speak about this theoretically. We need to have this data present. And I'll speak about the matter as I told you in general. I mean, we can focus on drafting our quality plan, you know, in the financial unit, in the pension scheme unit, or we can draft these plans for a specific department, HR, even in management or administration. And that's when we need to have clarity about what a quality plan is. It's an instrument, and in that document, we'll have to be very detailed. We need to guarantee quality, the quality of the products, the processes that we have. The products have to be in compliance with the processes that we have. Then we could ask ourselves what type of actions should follow, what type of resources do I need for the execution of the plan, and who's going to be the head of the planning. As point number one, we have first to identify that there's a need to develop a quality plan. It's strategically important. There should be a number two, liabilities, responsibilities in the center and directive units. All of the professionals involved have to be aware of the plans that they have, whether they're internal or external. They need to know what's going to be done and what we expect from them. And the, the quality control plan that's drafted has to consider, I mean, we have to understand and it has to include cultural differences or elements. Right now, we are working together in different economies, different countries, and these plans could be adjusted depending on the plan, on the country. And it's an object, it's a document that could be continuously improved. How do we improve it? How do we how are we in compliance with the quality of our processes here? We can have a unique plan with multiple factors that's like patient centric, in which professionals, coordinators, managers participate in the roles. We must never forget that there's a question, and the question is that how to do this, how to draft this quality document, this plan. It has to be an instrument that's detailed, that guarantees the quality of our projects, processes, and the products that we have. The plan that's detailed should give us the response to any inactions to follow. Number one, we need to identify first the need we have as entities to draft a quality control plan there. We have to write and draft the processes that we're going to have to execute in our institutions in compliance with the quality control instruments. If there's a company involved, these companies need to like also prove that they are under the accreditation, or they have like a control of their quality. They have to prove that to a third party. They have to prove that they are managing or administrating quality control to meet the requirements that other parties or insurance companies are going to ask them to provide. A quality control plan has to be, it's like centralized. We develop it for the entities or institutions. And for the rollout of the plan, we need to identify the specific requirements to execute the plan. We need to have clarity. We need to know which are our guidelines in our institutions. We need to know who are the third parties involved with us, who are our customers, who are the stakeholders involved, what type of resources do I have readily available for the purpose. Now, if there's other plans, it's very important to have all the roles and functions identified in it. Pardon. The scope of the plan is extremely important because it's the scope, the general scope of the plan. What am I going to achieve with it? I have to know if the plan is going to be only drafted for one project of the entity or the institution, or is the plan going to be for one of the processes, or is it going to be just the plan is going to be used in all the areas strategically? How am I going to implement it or to analyze and describe amidst all the actions that take place? Preparing ourselves for the quality plan to be drafted is something so relevant that we need people who are appointed to lead the creation of the plan in our institutions. As I told you, there could be some departments or units that have the task of drafting. It could be a cross-crop plan there for all our institutions. I mean, explicitly, as I told you, I was giving you the example of the hospital. Maybe the plan could be used to define a project or to define what's going to happen in an area, but after properly selecting and drafting, the team will have to compile all the instruments, all the documentation that's required to create the plan that's structured, that's going to be submitted at some point. We're going to have the proper matrix that contains data that will help us define the plan and have the proper characterization of it. The complexity of the plan depends on the needs that the institution, the business has. So we're going to continue working on this. I believe that the content of the plan, it has to be substantiated, and that the content will have to include all the data that's necessary for the development of it. It depends on some things. I mean, we need to have the right characterization of our plans, as I told you, the right content. If we ask ourselves, what could the plan contain? How is it constituted? How do we create the quality control plan? What's the scope of it? Which are the constituents of the plan, core elements, the objectives of it, the outputs, the responsibilities, who's going to be responsible for what? Who's going to have control over the document? What type of data do I need? What type of requirements do I need to meet? I mean, the design and the drafting of it, the frame of it, the procedures of control in it are important. The plan could be object of internal or external audit. We need to be capable of having clarity in the entity the plans for. That's our objective. We have to meet quality implicitly. That quality has to implicitly improve constantly for our society. How? With action, with strategy, with outputs. We need results. We need the right criteria. We need key indicators. That's part of quality. Let's see it next. And what type of focus? The quality control plan here has its core focus. There could be variance in the plan, but we're focusing on social security institutions and what frames it. There's clinical processes, services in the health field, and what's procedural. We need to improve our results. That is important. We're providing that service, that assistance. Our results need to improve. We're providing services. We're working as an institution. But then we have to, just this plan is patient centric. We need to focus on the external customers. It's very important for us. We need to increase our efficacy and have a decline in incidents or risks, obviously. It's all linked. It's all correlated. There's different points of our interest. There's internal groups, internal stakeholders, external stakeholders. Under this objective, which is our development, we have to work with quality indicators. For the services, due to the services that we offer, we need key indicators. And then parts that we have to meet quality and standards, will allow me now to share will allow me to share some other. We need to inspire a positive change. We are ambassadors of positive change in the institutions we work with. Now, we need to always be working as a team, striving to achieve top results, working together. Communicated between departments to be continuously improvement, to upkeep that quality, find the path to improve the quality of our processes. Thank you. So here, what we need as leaders, as directors, as elements that work for institutions on Social Security, this is what we should do. Here, I know that my slide is not well defined. It's a bit blurry. But and we speak about the assessment, how to evaluate the control of that quality throughout time. Here, what we have, we need controls in place to safekeep it. I mean, it's either we're doing things right or we're not doing what we have to do to make sure that the services we're providing are top quality, to prevent any defect, to achieve what we want, which is constant improvement. Sometimes we think we reached the maximum quality level, we meet our time frame, and amidst the pandemic, I stress amidst the pandemic, we have to ask ourselves, are we really offering the service with the right quality? We have to be very analytical about what we're providing. And just as a conclusion, I mean, when we speak about services that meet quality, that are given by us in social security institutes, I mean, it's like ethics is something that should be and must be present in all the areas of the health sector. That's our ethics. We have our core values embedded. It's in You remember, if we go back to the Holocaust, to that era in time, or I mean, what happened back then really led humanity to find some way to inspire ourselves, because there are situations that were simply unethical. I mean, and there are so many things that happened in that time frame that affected, you know, people's health. So intrinsically, the ethics is something that in health and in social security should be our guiding principle. Our principles in our management is we're we're benefiting. We don't want to harm anyone. We have to also have this other principle of autonomy, justice. There's injustice sometimes taking place, but ethics is something, it's an element that's present everywhere. In Costa Rica, in our institute, we try to analyze what's happening in Costa Rica. It's the ethics, bioethics, and ethics during research. These these concepts are very important, and more so amidst the pandemic. In Costa Rica, during this pandemic, we had to draft our guidelines, our protocols, how to, I mean, if our hospitals collapse, what do we do? I mean, if we don't have no any if we don't have beds in the ICU or intensive care unit, I mean, people that are going to be using services from us in the healthcare system, I mean, if they're going to ask for a service, they should ask for a service ethically. I mean, so everything must be considered, and these these elements should be taken to to their exercise. We're in a professor, we're in the biomedical research field in that discipline. So there's a bioethics principle, and there's regulators. All these core values and principles, they're our guide, and they should be present in all the areas of the process. So by mentioning this, I'd like to share this comment. The challenges that the healthcare systems face and Social Security, analyzing that future, have led me now to speak about the principle of universal coverage. That's our universal objective in the countries that we're in. And we, I mean, the more beneficiaries, the better. So I believe that in parallel to what's happening, we need to evolve and work to achieve universal coverage with the services that we offer. I'd like to thank you so much for giving me your full attention, and it's my pleasure to receive all your questions through Duo. Our doctor. Thank you very much. Excellent, Dr. Juan Carlos Esquivel. We thank you for sharing your splendid presentation. You're so precise, so specific about all the themes in the module of quality control of our seminar. You've given a robust presentation. You've shared about what's happening in Costa Rica and your understanding of what's happening globally. You're so strong when you mentioned your quality control plan. Obviously, strategic planning is something we can't do without, or else we have no heading. We need that heading. We need key indicators for the proper evaluation of that quality. It's something that's mandatory, or else this would be senseless. I mean, all of our effort without those elements would be senseless. Thank you once again. Thank you so much for accepting our invite. Now we'll continue now with Mónica Cañete, our doctor. She's an expert in auditing the public sector. She works for the Centro Médico Bautista educational institution. She's a pediatrician from the Catholic University. She's worked with different programs in Paraguay. She has an accreditation in damage assessment, environmental damage, and she's certified of public administration. She's the director of one of the hospitals in Ciudad de Luque in Paraguay. She's a medical coordinator in Danagua Clinic in the Institute of Social Security. She's also part of the Institute on Social Security in the central area. Pediatrician. She has her polyclinic in the central hospital. She has her own practice. She's also been a general practitioner in San Pedro Barrio Herrera, affiliated to the Central Hospital Network. She works in the San Lorenzo Hospital. She's also working for the health ministry. She's a general practitioner in the regional sanitary area. She's the director of San Pedro Hospital. And as a student, she's part of our seminar today. She's studying with us. She will present her work. That's work centered on quality and health. Thank you, Dr. Mirta. Thank you for accepting our invite. Well, first of all, thank you so much because in Paraguay, I'll tell you, there's a 3 hour difference versus Mexico's time. For me, it's a pleasure to be here representing my country because I am from Paraguay and I represent social security of my nation. And I thank the president of my institution, lawyer, the attorney Andres Lubatich, who has enabled me to participate in this seminar for top management. Now, with this seminar, what I've learned has been improved, and I'm really here at your orders. I'm here to serve you. So everything that we're going to be talking about attention, quality of the services provided to our population. The previous speakers I've heard throughout the day, they've been very very positive. Miss Ibel, Mr. Serrano, I it's like they shared with us the whole landscape about what's happening amidst the pandemic in Paraguay. We could say that we were one of the first countries in the southern cone of Latin America to decide to confine as an immediate action when we faced one positive case in our country. First, we had to close our borders via land and via air. We shut down, and to we started to think about our protocols in place amidst the pandemic that made all the healthcare services.
both for private and public sectors, like Instituto de Protección Social, it has a given amount of assured occupancy for whoever is sick. Well, we really started uh, looking into everything pertaining to biosecurity for patients and for personnel or staff themselves. So, just in going directly to subject matter now, I will talk about quality and security, and the health of populations and patient security. So first comes in introduction. During 2020, we suffered strike of the pandemic, SARS-CoV-19, and to counteract, we looked for strategies to be used, both administrative and sanitary. We do have a world guiding organization, which WHO, that determine provisions by security for staff in wide as well as for management of population around the world. All countries immersed in this pandemic only presented problems regarding the disease and as such, but there were also important socioeconomic problems. These socioeconomic problems included commercial problems, closing of non-priority activities and place of business in my country, because I did this work practically based on what we were led to do during pandemic. Rethink what was prioritary in terms of our service, restaurants, food delivery services, who which brought food home. In the financial aspect, we had the economic stagnation, not only in my country, but because of the isolation. We had to start looking for other ways of getting inputs we needed for hospitals, because since flights were canceled, land transportations were canceled or immediately at hand. Things that were stocked for we had to see how we could use to benefit only our staff members, but also patients. So in biosecurity, we had all the elements necessary to improve hand washing, take temperature of people, telling the visitors how they had to walk and move inside our facilities, what the isolation should be, what was considered healthy social distancing was. And we did all that in the beginning. Practically during the first 6 months, we started providing everybody with biosecurity equipment, everybody working in ER, everybody working in medical offices. Like Dr. Esquivel before me said, that we eliminated certain areas of specialties that had aerosol emissions, flow emissions, like odontology, areas of specialty, which wouldn't have that much incidence, everything pertaining to psychology, psychiatry. We also implemented telemedicine practically 6 months ago. Our hospital is a satellite hospital in the outskirts of the city, and we have a population that's plenty, not only locals around the airport area, but from other areas. And we really had to see everything pertaining those strategies. We dealt with statistics on a daily basis because the health ministry was in charge of providing how many people infected we have, the amount of people going out of the situation getting better. In the beginning of which we've seen a slight increase in the amount of people infected in our country. So that makes us double our efforts to try and decrease that amount again, the amount of people currently infected with COVID, and some getting reinfected. So we prioritize the refurbishment of new wards. We have some hospitals for COVID cases. We have hospital for elderly people, geriatric medicine, social security area. It depends from my hospital, IPS, the institution I currently work. So we made that refurbishment. We increased pavilions. We increased the number of beds for therapy purposes. We made patients visible, patients under 60 years of age in a hospital devoted exclusively for COVID patients under 60 years of age, and children and pregnant women attending that place. We hired extra medical staff, specialist physicians, nurses, all that in preparation for the coming of the vaccines. We just received around 4,200 doses, which is only about enough to cover first responders and doctors in therapy areas, and first line personnel in direct contact with patients. So we resorted to awareness campaigns in the media, and this entailed a very important contribution to try and mitigate the increase of infection amongst the population. Right now, we're carrying out an assessment of patient security as a set of organizational processes that reduce the probability of adverse events resulting from exposure to medical attention system along diseases and procedures. So this comes from one of the processes that we saw in this diploma course. So now we're trying to replicate this and to widespread this for all of us to have a better idea on how to better handle, how to better manage the situation, which is really new. It's really new for all of us. There are segments of population around us in other countries, in Brazil, in Argentina. These countries have more population, and of course they experience more deaths. So all our bordering regions were coming and going, whether borders would be closed or not. Then, of course, this entails very important recession, people counting and tourism coming and going through these borders. So we really need to look for ways to get resources to be able to provide satisfactory attention to the population. I mean, obviously, the executive branch in our country lended us a hand. Everybody, at least to everybody in the border regions, and also at the IPS, Social Security Institution in Paraguay, we put all the necessary pieces of equipment for us to be able to reach our patients. We try to help people follow follow their treatments. We've made a division of emergency medical offices. We saw patients with respiratory problems, and we separated them from other patients with heart conditions. We tried not to mix patients. Sometimes we had patients with other comorbidities, and we couldn't take them to respiratory ward where we had patients under suspicions of having COVID. So we need to look for the way to provide security to the patient and to the physicians. Physicians in the respiratory ward had to be properly equipped by a security gear, surgical gowns, avoiding patients being harmed due to medical interventions. In the very beginning, we suspended all surgeries. Afterwards, we started doing them after swabbing all the patients. We gave them 72 hours after being swabbed for them to enter surgery. Given the fact that their surgeries have been postponed many times, and we were trying to reduce the waiting time, which is harmful for the patients. We tried to make medical staff being assertive. We promoted services based on scientific knowledge to everybody who could be a beneficiary of that. We arrived at efficient service that decreased waste in equipment, inputs, a service that's equitable. We are a bilingual country, so all our physicians speak two languages, Spanish and Guarani. And patients coming from the inside of the country, from the city we're at. Sometimes people talk Guarani and they had to speak Guarani back to them. Everything pertained to medical medications. How should people take their medications? Times. They had to speak to them in the language of their choosing. We have some insurance holders inside of the country who only speak Guarani. So attention was focused on patient mainly. And, you know, and we told our medical staff that they should treat everybody with respect, and they should be taken into consideration in all clinical consideration, in all clinical decisions. And following the scope of this evidence-based medicines, we need to be guided by bioethic lines and established or set forth in the law. These bioethical principles might be seen as decision criteria, which are fundamental, which health professionals need to consider in their deliberations regarding what should or should not be done in each of the situations that they face in their day-to-day activities. So we're trying for this international trend, establishing four fundamental principles, like Dr. Esquivel before me said. And the commitment of each of the professional, everybody carrying out any type of attention in the hospital, both in the admin area and managing the operational area. It's our commitment to do good and following the principle of not doing harm, because I mean, to trying to make good instead of making harm, more good than harm. That is to say, autonomy, that's respect coming from the will of the patient, and justice, that's the equalitarian distribution of loads and benefits in our actions. We try for the patient to come with a symptom, and for us to try that symptom to be channeled to specialty hospital, because right now pretty much everything we're doing is serving as ER, because my area is under construction, the hospital I'm at right now, and we will have an increase in hospital beds, so we're trying to cover ER area. And well, this is not a like a hospital reference for COVID patients. Like I said, we referred our patients to different hospitals that did have COVID area. So we received the patient, we kind of triaged that patient, we made them stable, we stabilized them, and then we referred the patient to 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 COVID hospitals. So we try to handle this in the best way possible. So well, that's about the service, attention services that we were rendering. So this pandemic made everybody look for the most explicit mechanisms, the most direct mechanisms for the patient to spend less time possible without attention, for the patient to receive the attention that they deserve, and also provision of first need inputs and materials. We're experiencing that problem. We were trying to look for options to get those materials, because we couldn't get them from outside the country. And when we started getting hospital beds to increase the number of wards and attention, because all therapies were increased. Right now we have, any given amount of therapies available. We have therapists, we hire therapists. So it's really a matter of trying to do our job, adding up efforts, and coming up with something that's valid for our staff and for the insurance holders in this case, and patients in general. So this really made us become aware of the fact that we're still far away from the real and correct. And right now, this hit everybody. And based on all communications, based on all technology we have readily available, in the advances that there are, and in reaching the whole population, we had the information that we were the only country with many problems, with many needs, with scarcity. We weren't the only country facing all sorts of problems from a technological standpoint, even lack of staff, personnel, training even was a constraint. Training handling this pandemic that made us learn something every day, that made us look every single day for information, do the way we can to be able to best share this knowledge with the population, while at the same time trying to make population aware about the fact of the biosecurity measures of social isolation, social distancing, 2 meters, living 2 meters between or among people. If you're going out or you're out with friends, try and keep all these biosecurity systems in place using a face mask or mouth cover. Right now, it's hot season in it's summer in my country, and using a face mask is hard. We have to have them on for all times. If you're in the hospital for 12 hours, you'll be using the biosecurity gear for 12 hours. And really, if you add hot to the mix, it's really suffocating. And our personnel have gotten used to that, and how to do things with the utmost degree of biosecurity. And we're trying for this information to reach everybody. And now I think that with the second coming, with the increase of people infected with COVID, I think that will be a number of 1,100 people infected every single day. We have around 15 deaths per day, and we're a population of 7 million inhabitants. So we've reached a point in which people are kind of tired and sick of the use of these safety measures. And all measures become a bit lax, and that's why we started seeing these big amounts of that really makes us increase our efforts to be able to come out again of this peak that we experience, this peak of infections, and to see what is it that we can do to be able to maintain that security that we had during the whole 2020. We tried to reduce the number of people infected, of deaths, and we really made a conscious effort to preserve the lives of people over 65 years of age, because they're a vulnerable group, and even physicians over 65 were still working their profession. We told them to stay home, trying them not to be in contact to the hospital with given amount of patients, to safeguard their lives. Children stopped going to school, and we resorted to virtual education, online education, and without preventing the people from, children from getting infected. As of next week, public schools will open doors, and there's some parents not wanting to send their children back to school. They want to continue with this online modality. So we're also looking for alternatives for all the necessary measures, even to be able to meet what everybody wants, and to avoid the number of infected people to now start coming from schools and children, because they were isolated. They kept themselves at home. They didn't go with their parents to supermarkets and so on. And that's why they were kind of safe within the households. So, we were really trying to meet these requirements that we needed to better help and maintain, kind of stabilize infections, a pandemic, being able to care for patients, not to keep patients waiting in ER, trying to improve our intake processes for patients as much as possible, avoiding them being inside hospital for long periods of time. So we managed to do all that. So we were together. We had different teams: medical area, admin area, nursing area, and really a teamwork. Trying for physicians to give right indications, nursing staff to comply with these indications, making sure that medications are really available. That's from the admin side, everything that the Institute of Social Security could facilitate in terms of materials. And at the same time, we had like a small cash box in the institution. So I mean, whatever the institute could not provide, well, we had to get from this cash box that we had, and that helped a lot. That made us not be short in biosecurity gear, some medications not to be scarce. Whenever there were surpluses of materials in some hospitals, we sent to other hospitals. We made some sort of bartering of medications and or exchange of medications, and we started supplying also everything that we had to do to in terms of management to avoid scarcity for I mean to avoid us saying I cannot do this, I cannot do that, and like, we did all that through sharing. So I guess that security really depends on the responses that we get from our authorities. We do have a Ministry of Health looking far and wide to get vaccines because we just got this 4,000 doses. That won't be enough to cover all the frontliners working in the pandemic. And it's really a sliver of hope getting the vaccines and see how everybody reacts to the vaccine because we're getting vaccines from different countries and see how the management will ultimately help us for us to be able to relax a little bit more because right now we have a peak of infection and how people have been a little bit relaxed before this because they're tired of security measures. They tend to not to believe what the health ministry says, public areas say, or ourselves within the society, the community. That's why we try to look for the way to have a little bit more credibility about this subject. And I think that my country is not the only country experiencing this. I think that this is happening all over the world because people found themselves locked inside their households. They no longer had the freedom to go out and have fun. Everything was controlled. At least in my country, we had some protocols for business hours, restaurant hours, and people had this type of schedules, or if they had to go out later at night, they had to have some sort of letter from the boss or whatever saying that that person had to be out of hours. And well, I've said this many, many, many times. Because of that, we increase infection in the country. And right now, we're waiting for more vaccines, like I also mentioned before, and we hope that this will help control that anxiety people has.
Or and just to so they could relax. And we we really need hope. That's what we want. We know that we hope that this will improve, not only at our national level, but I mean for all. I mean, we hope everything's fine as it should be, and we have that spirit of commitment, of trying to move forward, of trying to find the best way for all of this to finally end. You know, I know that this year has been packed with ups and downs, and we have to improve. We have to be out of it soon. All our countries, all the governments, all governments are doing something. There's action from the government side. We're trying to find areas that could make us move forward towards those solutions to try to satisfy all the parties involved. You know, our first responders and the patients. It's difficult. It's difficult. But that's what we're trying to do. Us as managers, directors, we're here all day analyzing what we have, what we don't have. There's so much happening. It's there's so many situations that have led us to simply having to do things. You know, there's like actions being suspended even though there's protocols. We've tried to be as objective as possible. We've tried to find solutions. We've tried to provide the proper response somehow. The patients come to us because they need solutions. We've worked on the implementation of telemed, or and because the network of hospitals in the peripheral areas, that are part of the social security, not always have specialists in their field. I mean, most of the physicians who have their areas of expertise, and there's people that have to go to other hospitals in that network in the peripheral areas, but the expert that they need is only found in the central hospital, and the person that can solve, in the central hospital, is just there. I mean, we can't just have patients going from one place to another, or just tell the patient, you have to get your number to have your appointment so you can have access to the practice of the doctor. And I mean, we can also give them some level of attention using the telemed or services. When I'm talking about for example, images, or MRIs or scans that could be sent to the central hospital, to the doctors that's there, so they can do something. I mean, we're talking remotely. It's about doing this remotely. That's what we're trying to do now. It's part of the implementation, and that's pretty in my country. But we are we are creating, as I mean, as we speak, the controls we implemented in in informatics or computer science. We implemented, for example, the use of computer science to have like all the procurement there in our labs, there in our log. And then you have, for example, the doctors working behind the computer, analyzing the results submitted by the lab. So in Mexico, I know that, I mean, or sometimes, I mean, it's like we think about how we don't want to expose like our patients, and now we're working constantly on sanitizing hospitals. We need to work to sterilize everything. We need to sterilize all the hospital wards, the units, the equipment we use. All of this is being done to avoid the spread, or the spread in the and have, I mean, we're trying to protect our physicians, our patients. Now, I mean, if somebody uses a computer in a unit, I mean, somebody walks in right after to sterilize it. So we're managing things to keep everyone safe. In these units, we try to, as I told you, sterilize everything for both parties, doctor and patient. It's part of what we're doing. We're in compliance. We're doing what we can in Social Security, and that's what we've seen. For me, it's been an honor to be part of this workshop. This seminar really has like opened up my mind, and I'm here receiving all the information. I'm storing it, I'm compiling it. You know, I know that this theme, the pandemic, during the pandemic, I can tell you that I've implemented what I've had to implement in our structure, managing our staff. We've had briefing, and we've been briefing and debriefing with our staff. And if there's a staff member that's not satisfied, or that they're in a unit that they don't like, and or I mean, if 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 that were the case that I'd face at some point, I tell you that this workshop has helped me to increase my experience, you know, based on what we've done in my country. I'll tell you that all of this knowledge here in all the areas or sectors, or I'll tell you that it's been positive. It serves a purpose. And in the hospital, I'll tell you, I've been using tools that have helped me a lot. And I thank Dr. Dubois, thank you for being a facilitator, for giving me the opportunity to be here expressing what we've gone through. I mean, amidst the problems that we face now. Thank you very much, Dr. Mirta Cañete. Excellent presentation. We thank you for it, without doubt. Healthcare institutes, hospitals, hospital networks, the centers, I mean, these are complex institutions because they're multidisciplinary. We integrate human resources, material resources. The structure is in itself complex. There's technological, scientific progress, development. There's models, protocols to provide the right attention to our people. And with all of these, there's risks correlatable to all these actions too. I'd like to thank you very much, Doctor, for having shared your experience in Paraguay. Without doubt, this pandemic has been a challenge, a daily challenge for all people, all healthcare professionals. Us being in the hospital networks working, we know we are working there. We know clearly what's happening. So thank you for having expressed what you've lived through or gone through. And thank you for talking about the patient and the doctor's safety. And, you know, we're all facing this challenge. Thank you, ma'am. Thank you. Well, now we're going to continue with the introduction of Mr. Carlos Alberto Solano Salas, general practitioner and medic doctor. He administrates different healthcare systems. He has achieved many degrees from Santa Lucia University. He's also been accredited with the Inter-American or the Center of Health in Ikai. Currently, he is the manager or director of the clinic in his one of the top clinics in his country since 2008. He's been the director of San Diego San Juan Construcción, part of the program in his country, and he's developed healthcare plans. He has worked in San Juan Concepcion. He's developed the plan to provide the proper service in the medical field. He's been in research. He's been also working in developing the infrastructure of the institutes. In 2016, he had that project in the clinic Picado, and he's also been in the other clinic in Uruca. He has a lot of experience. He's been a professor. He's been coordinating professors in the healthcare field. He's also been clinic called Clorito Picado. He's also a consultant in many clinics, and he's also participating in different conferences discussing topics such as management and in what's happening in the medical field. So as I've told you, Mr. Solano Salas is going to be talking about what's happening in his healthcare system. Dr. Carlos Alberto, we welcome you. Thank you for accepting our invite. Thank you for being a distinguished scholar and student of this seminar. Well, I'd like to thank you, Doctor, for giving me the opportunity now to discuss with all of you the subjects that we're going to be discussing as part of our seminar. So I'd like to thank the Inter-American Center that on Social Security, but thank you for allowing me to participate in this seminar. I mean, it's of great use. It's very positive for all of us. I think that you can see I'm sharing my screen. I think you can see my slideshow. And you can see my slideshow, right? Yes, doctor. Yes, please continue. Thank you. As it's been said by your introduced part of the work we've done, when we analyze the 6 dimensions, the key 6 dimensions, which are fundamental, as I've told you, in the healthcare system. It's like crossing the quality chance healthcare in the 21st century. That's the report. It dates back to March 2001. In that report, there's data that's analyzed because we analyze the services systematically, the services that are provided in the USA, and the quality of the services provided by those involved in the medical field. We measure gaps, and we want to narrow the gap between like the demand and the need there is. So there's other keynote speakers that could say that we know that the U.S. is a you know is a top economy, and in their system there aren't mm, there weren't many deficiencies, but during this pandemic we were capable of analyzing the gaps. We know that in our systems there's certain areas in which we have gaps, and if we analyze the dimensions, the 6 dimensions, we will have to analytically understand the systems. And in those gaps are areas that we could improve. So what can we do? We work in this field. What can we do? One of the factors that were object of analysis was the accelerated advance that science and technology has had. I mean, right now, science and technology I mean, those fields are just developing, they're growing. I mean, at this time with such celerity here, I mean, and that's one of the things that that acceleration and that growth, sometimes makes us lose our north heading, but at the time being, there's also another factor that's like a high complexity, an increased complexity in the medical field, in the services. I mean, there's many stakeholders in this actions involved. I mean, there's the doctors, the administrators, or stakeholders, the observers, different actors involved, people that bear knowledge. We're using technology. We have to analyze the complexity behind them all, behind those technologies, and understanding that is something that we must consider to attention. I mean, it's not, we have to improve the healthcare systems, the lifespan of our people, to raise hope. And our people or patients suffer some chronic diseases, and we know that the quality of life throughout their timeline, I mean, our people will need to have access to the healthcare systems to treat those chronic diseases that they might suffer. But I mean, in our system, our healthcare system is focused on acute healthcare conditions. I mean, some in in our in our field, we can see and analyze or study what's biologically affecting the person, like as an entity. I mean, the patient in place, I mean, is a person that has interaction with others and family. So we have to understand the patient in general, broadly, not just focusing on one area. Sometimes when we lose our north or our heading, we think, okay, I have an area, my area of expertise is this, my field is that. And if you're an expert in a field, then you might forget that there's other problems that the person might have that are not my expertise. I could say, okay, I'm an expert and I can understand the right nostril of the person, but let's take this further. I mean, there's a lack of clinical programs, multidisciplinary infrastructure. There's that gap. So we have those gaps, and it's necessary to narrow the gaps to give the proper attention to people that suffer chronic diseases. How do we maintain this? We have to analyze what's happening with our infrastructure. Maybe we lack infrastructure. We need the infrastructure that allows us to really have action in a multidisciplinary way. I mean, it's not like, okay, you just give the patient one pill and that's it. Okay, you have to take care of the patient. You give the patient the pill and think about knowing the patient, and know their lifestyle and their current lifestyle. How do we improve it? We need like no silos, or I mean, we need hospitals that are well organized, that are well communicated. We don't have a network in this field that could like somehow, if you have a patient that's suffering a complex case and then you have to transfer the patient somewhere else, and the communication of the first attention that the or the data that was obtained from the first appointment that the patient had maybe is not communicated properly to when the person sent somewhere else. So it's like we're working in silos. It's like an island on, everybody works like on their own. So communicate. What do we have to do? After analyzing this, we have to make change feasible. We are talking about reengineering, as Dr. Esquivel said. Reengineering, redesigning is part of the challenge for this to become material, factual. But this reengineering doesn't happen from one day to the next, right? In a snap. It's a whole process. And that process is a constant. And then we can see what happens at work. We need to redesign and apply the right level of efficacy in our management towards that change. We know that holding information is holding power. I mean, you can have so many systems, and we can work with a lot of with computer science and use big data or big data. And by using big data, I mean, yeah, we can have all the data. How do you use it? How do you implement? What do you do after you you process the information of the data you have. I mean, in the systems, in computer sciences, if you feed data that's not reliable in the technology, you're going to obtain unreliable data. So we need to obtain quality data, reliable data, and feed it to our system so we can obtain outputs of quality. We need to manage our knowledge. We need to be capable of administrating our knowledge. We have that knowledge thanks to big data, and we need to have like instruments or devices that are efficient enough. This is not out of reality. What we need to do is we need to do sometimes more or less, but we need to be exactly working to achieve that efficacy and profit from the material resources we have. Versus, I mean, when you think about the supply and demand, satisfaction of the need, the coordination between stakeholders. I mean, there's a patient, there's a doctor, and then, I mean, we have to connect, connect all this to Social Security. We were talking about infrastructure, the quality of our infrastructure. What we provide, our services depend on the quality of our infrastructure. We speak about our patient safety constantly, but that depends on having us meet those requirements in our management. That have our management has to be the right management. What are we going to do in this flow? You can see that with this design, we can create a structure organization that facilitates what we do for our patients. It's centered in the patient. What we do is that we need supports, we need to pay, there's regulations, and all of these elements will allow us to systematically take care of what's happening with our quality as well. Why? We're going to see in this flow the outputs. We need our results to be safe for everyone, efficient, achieve efficacy. It's custom made. Everything has to be done timely and under the principle of fairness, of equality. Here, I want to talk to you about the 6 objectives that will lead us to that improvement. Progress should include, in this progress and this development, we need to include point number 1, healthcare professionals. 2, protocols, the right documentation, state policies, federal policies. I mean, we need the policies in place, the provisions in place. I mean, at the end, who's going to guide our heading? I mean, this will lead us to the heading that the provision should be aligned to our objectives. There's the regulators, there's procurement processes, which, I mean, procurement could happen in the public field or private field. We need to think about the managers of the structures and directive or steering committees. We need to think about consumers. All of these elements, as I told you, our stakeholders are many, and all of the elements should be aligned towards that north heading and that guidance, all on the same path so we can achieve the core objectives for that improvement. We need to organize ourselves and improve the healthcare systems as we wish or desire. What's the objective of doing this? We need to reduce continuously the load of situations that our people suffer, like disease we're fighting, and harm, trauma, disabilities. So we need to improve this. That's what what we're trying to achieve always, those 6 points. We are working for the improvement in the healthcare field. We need to improve the health of our population, of our citizens. Now, we have 6 objectives for that improvement. I mean, we need to reduce unnecessary damage and have a decline in risk. We need to take care of our patients. I mean, if our patient is going to be subject of a procedure, whatever you're going to do to the patient should not have collateral risk or harm. We need to work, but in understanding that we need to prevent further risk or damage or trauma, because the cure that we use for the patient should not affect other areas or the patient. I mean, sometimes we try to implement a sophisticated procedure with top technology without previously being capable of being deterministic about the safety of that patient. I mean, in this case, it could be efficacy. I mean, there's always hard data we need to obtain, hard data for patients based on science to be capable of providing the proper service or attention to the patient. The service that's going to be received by the patient should be, then materialize after there's like a lot of scientific evidence studied before. There's a diagnostic, and then there's a procedure, there's the implementation of the order of, or all of these steps. You know, sometimes we're in certain circumstances, and okay, we have a patient and we give them a set of instructions, or we tell them, okay, you have to go to this place and study and get this analysis, get your analysis, and then come to the appointment to so the doctor can decide based on evidence on what's factual and investigate, do his or her research. And after doing this, then a doctor can decide what type of treatment could be offered to the person. I mean, at the end, we have our objective, which is to improve the health of our people. We improve based on scientific knowledge, hard data. We follow protocols, presets protocols. We've said this before. What I'm about to say has been heard before. Dr. Serrano mentioned it this morning. Everything is centered on who? On the patient. We center our attention on our people. And the patient has to be safe. We have to be as efficient as possible for them. Everything, everything that takes place, or everything that happens when we have our policies, our guidelines, if there's new technology being used, we have to use new technology and the rest to benefit the patient. We're centered on the main stakeholder, which is the patient. We have to timely. Many of the problems that we have at an institutional level in the healthcare field is we need to have the right opportunity and the right time to give the patient the right attention. There's conditions, there's pathologies. I mean, there's conditions that, I mean, if we don't attack the condition that the patient's suffering, that affects them even further. So we think what's going to happen to the person in the long term. Sometimes we have to delay a procedure. Sometimes we delay in some analysis, and that affects the patient negatively. Now, one of the experience, I worked in my field with a program called On Time. On Time, we want to have the patient there waiting at least as little as possible, because if somebody comes to us with breast cancer, time is extremely important. We have to analyze the person. And that, I mean, getting your breast analyzed should take less than 30 days. I mean, we have to change our mindset. And I mean, sometimes, okay, we receive a patient with a general practitioner, then the doctor sends the patient to get an MRI or a scan to see, and then we have the electronic file of the patient, and in that file we have all the information. We call the patient back and we invite them to get a checkup of the situation, and there's an appointment, there's a specific date, time. So we wanted to eliminate like our procedural sort of like or patient backlog somehow. We want to eliminate delays. We want to be as efficient as possible. As I've told you a moment ago, everything we do has to be justified. Everything has to be organized. And everything we do should be done at the lowest cost possible in compliance with quality for health.
So this is one of the important things to remember here. Everything that I have to do needs to be equal. It doesn't matter where that person comes, long distance, short distance, background, culture, religion, belief, socioeconomic level. That doesn't matter because equality needs to prevail above any of this, and nothing should ever be above of healthcare for people. That's why our caja, our social security, amongst its values, precisely that equality, to avoid these circumstances, and for patients to actually receive whatever they need according to their needs. As a conclusion, equality medical attention needs to meet 6 dimensions I probably described, and well, there cannot be quality in absence of any of the 6. So they of course complement each other to be able to arrive at quality we desire. So when you place patient healthcare central access, you look for attention to be efficient, timely, equitable, and secure. This problem, a poem written in 1961, and what it talks about is how if we miss small details in our work and patient care, that can bring about big problems in the future. It says that if you don't have a nail, the horseshoe was lost, because not having horseshoe, that's why we lost the horse, because losing the horse, that's why the knight was lost, and because of the knight, that's why we lost the battle, and because we lost the battle, that's how the kingdom was lost, and everything was because of a missing nail. So if we neglect a little thing in health sector, might bring about big problems in future in the country's social security. From there, the importance that we're constantly aware, analyzing, and that we're striving for continuous quality, something that we should be providing in our service to avoid that nail to bring down our entire system. And I just wanted to show you a little bit of landscape in our country. This is Lancaster Botanical Garden from the University of Costa Rica, where you can find a big diversity of plants, trees, flowers. There's some pictures from our beaches. Rainforest and a little bit more of our beaches. So that's it for my presentation. I would like to thank you for your attention. Mr. Alfaro, congratulations for your great presentation. Thank you very much for sharing these very beautiful pictures from your also very beautiful and rich country. And what you mentioned is really important, because if we take into consideration that mispractice is a consequence of lack of attention to all these precepts that determine quality medical attention, and that in turn might bring medical liability. That's why it's important to dig deeper into all these concepts, all these matters that we've seen and security need to happen preemptively. That helps the whole health staff and institutions so as not to incur in liabilities. So again, thank you very much for your presentation. Thank you very much for accepting be a part of this seminar. Next, I have Antonio Alfaro Sotomayor with us. He's a physician and surgeon by the medicine school from the Universidad Autónoma de Nayarit. He has specialty course on family medicine by ISTE and UNAM. It's a master's degree in public health with specialty in health management by the Universidad Autónoma de Nayarit, with a diploma course on medical update for teaching in medicine by the Medicine Council, the Medicine Council of the Universidad Autónoma de Nayarit, diploma course in IT, another in administration of social security institutions, and a diploma course, online diploma course on managerial skills in medicine, all of them from Universidad Autónoma de Nayarit. He's been a speaker in methodology of security and hygiene, pathology, traumatology, and as a professor of clinical cycles and as an instructor in the security and hygiene program in the framework of the professionalization project of the Tepic Technological Institute, Mr. Antonio Alfaro. He's a Mexican national. And he will present in a video you already know Alliance for Intern. And you're one of our keynote speakers. And I will now pass the floor to Dr. Alfaro. Thank you very much and good afternoon. I would like to thank Dr. Carmen Dupont, CS, for allowing me to present my work. And I mean, after listening to peers before me and after attending to the seminar for a full week, I think that everything is excellent. It's without a doubt that all of us are improving many aspects. In this case, from the patient security standpoint. So I saw the different modules of the diploma course. We started out with management based on evidence, main skills of directive staff, organizational development, and finally comes quality in health institutions. So in reality, these portions, specifically my subject matter, that's the analysis of the video, is a reflection of what we don't want to happen. I think it's in reality what we should avoid with all the previous knowledge or all the knowledge that we've gotten from previous presenters. I'm sorry, doctor lost internet connection. And before, I mean, we've always acknowledged medical mistakes that have brought harm, disability, or death in patients. If we go back to ancient times, I'm talking about the Code of Hammurabi or the eye for an eye law. There was always punishment for bad practice or mispraxis when there was a specific situation about poor quality medical attention, even if that was required as such back then. So I would like to briefly define what we understand as quality. Quality we can understand as a set of qualities inherent to something that allows to characterize and value it based the rest of its species, something that's good quality. We can also understand it as superiority or excellence of something or someone, something it's of good quality, having good quality. So in that sense, we understand that WHO back in 2004 made the World Alliance for Patient Security, thus generating a series of initiatives and strategies to be able to minimize, to decrease many mistakes physicians were making. If we were to summarize some data, and I also should tell you that this is of course a problem of public health, and we need to understand that out of 10 patients that we care for in sanitary environment, at least one will have a problem. Out of these 10 patients, at least 50% of damage or events or adverse events could have been prevented. Worldwide, WHO acknowledges the fact that there's 1,540,000 adverse events because of non-secure environment in hospitals, and this caused around or more than 2 million deaths in hospitals. And we also understand years lost because of disability and death in patients. So this, of course, impacts directly the economy, and it impacts the health system of each country or each health organization that you might constitute. We also understand that this incurs up to 15% of the health budget to be able to pay for all these mistakes and adverse events. We, of course, mistake might happen at any point in time, and that there's a chain of events that affect the patient directly and the organization itself. Because it will generate, but we don't want poor quality of care. I don't know if you can see my presentation there. I'm trying to share my screen at this point. All right, can you see my presentation there? Yes, yes, we can see your screen, doctor. That's it, doctor. And yes, we can see your screen. Just doctor, please try to blow up your screen. Try to go into full screen mode. There it is, doctor. Thank you very much. Okay, so let's continue. So, like I mentioned, errors can be prevented, but it really depends upon the whole set of knowledge guidelines and the legal framework that we have in each country to be able to avoid them. Everything that we've talked about in this diploma course leads us to the product. And what's a product? This a module in the diploma course, that's quality. So everything might be great, from the organization, improving organizational culture, improving upon everything that's evidence-based in management, and so on and so forth. But if the fundamental aspect is not clear to us, the product that we're trying to come up with, I think that we're up to a bad start. Also, the video, we make reference to medical mistakes and the lack of security in caring for patients, and these are very frequent. We point this out through statistics, and the first doctor spoke, Dr. Milangeli, pointed out this very clearly, and Dr. Carlos before me also talks about very core, very fundamental aspects behind this. So watching the video, like you mentioned, seems like really fatal situations, really fatalist, because we understand the human side of this as a good practice, and not having ill will, not doing anything that generates problem with the mission or negligence. Something that we're aware of. And when we act because of the volume of work, because of all the sanitary complexity that we might have, that leads us to making a mistake. So, being Christina is an oncologic medicine I've used, and like the video mentioned, well, somebody applied it in the spine, which brought about paralysis and death. So imagine the trauma that was generated in that environment to the organization, and the patient didn't even know what happened to him, what they did to him. So that's the most serious thing of it. How from one moment to the other, I mean, the society can label you as a murderer without you obviously wanting it, without you meaning harm for the patient. Now, in case of the video responsible is pointed out as Dr. Campbell, and he made a mistake in injecting vincristine in Dr. Hughes' spine. So this was actually a chain of unfortunate events, because there are protocols in the hospital that are clearly recognized, but why are they not followed? Why not having patience and tolerance to be able to wait a little bit and verify things? So to this, other situations contributed, like patient being in a hurry, workload, even aspects in medications and placement of medication. Sometimes unexpected situations where the nurse had the medication on her, the methotrexate that's what should be applied, but she never said it because she had to go see another patient. So we understand it in this clearly mentioned literature that medications should not be stored in the same refrigerator. They should not be combined. And these two medications belonged or come from the same laboratory with very similar labels, which is something serious. So we can understand that within the legal framework that we have, for example, which is Article 4 in the Constitution, which is the right to health, and we find the General Health Act, and where it sets different guidelines for patients. Everything leading to very specific care and medication application. As it's clearly pointed out in international goals for patient safety, it's fundamental for all medications. I mean, knowing what medication it is and who you're using that medication on to have that perfectly defined. So the standardized processes were there, but they were not followed. Something else has to do with hierarchized working structure and work stress. So the stress we're subjected in our hospitals and our health institutions. What happens? We have an important workload, a very demanding patient, who's affected every day, even from the human rights standpoint. That's very linked to this. So there's not one health organization that does not vulnerate human rights of a patient. Simply, not being able to provide someone medication because you don't have it in stock, that's vulnerating someone, so violating someone's human rights. Sometimes we don't have enough time to care for each patient, so all that might lead us to a consequence. And the hierarchy of the administrative structure means that everything goes through different hands, different opinions, and that might have an impact on whoever's providing the service, the care. So you have a clinical chief, then the partner chief, then you have the clinical staff, and that hierarchy will impact on everybody. And people don't have opportunity to express something that might be important at some point in time. So the lack of skill and negligence to administer potentially lethal medication. So we obviously need to have well-trained people, correctly instructed, trained. But the WHO also acknowledges, because we're talking about negligence and lack of skills and medications, and we usually turn, to second, third levels, surgeries and other type of procedures. But the WHO acknowledges then even 4 out of every 10 cases happen in the first attention level, primary healthcare, and that's serious because within first level of attention, procedures are more reduced, both second level, but we're still making mistakes at this level. So the hospital, of course, has guidelines, rules, standards, and many times we set them aside. We don't follow them. Sometimes the hospital aligns or has to align to what we believe, to our ideas, and that leads us to different mistakes and problems that will affect the patients directly. Now, talking about culture, what's safety culture? Culture is defined as the set of beliefs, attitudes, and behaviors that characterize the actions of a group of people within an organization. So we can understand that culture might be something that's good for me and for others. That is to say, we need to place ourselves first in this central axis of what cultures is, to be able to understand and to be able to provide to the others what we think is good and right for them. If we don't do this in that way, we're not generating a culture, because we want others to have the culture, but we don't allow ourselves to be immersed in this culture. In an organization, security should be priority. The security of patients should be priority and a fundamental component. And the reality is that all of us talk about this, but many of us don't do it. So we need to reconsider, we need to reflect upon some integrating aspects of the whole organization and organizational culture, so that we can take the organization and lead the organization to generating a true security, a true sense of security, so that the patient, when that person arrives, feels safe and feels properly taken care of. So we shouldn't lose sight of the fact, just going into a doctor's office, or whether it's a hospital or a clinic, a hospital of second, third level, there's a risk inherent to that. Just walking to a hospital, there's a risk. So that this Christine video is so one of the instances made by the World Alliance to make people aware. And we see these problems every day. Nurse that injects a little person, first level establishment, that person is put in a stretcher, and when she turns around to inject that person, the patient might fall from the stretcher. And what happens? Well, patient went in for a shot for an injection, and patient ends up with a contusion, different contusions, probably severe contusions. So that's where we might start asking ourselves whether we're actually doing things correctly, whether we're really following the guidelines and standards of the hospitals and organizations, or if we're being or self-sabotaging ourselves and being accomplices of negligence that will lead us nowhere. So fundamental aspects, being aware that things might go wrong. Of course, many times we need to work by being defensive. We need to execute evidence-based medicine, but we need to corroborate those evidence, be trained to be able to shift that situation so as not to go into a larger problem. And we should be able to acknowledge mistakes and learn from them and act as a consequence. We need to have that vision for people in the organization to have certainty about what they're doing. There's situations linked not only to the individual but also to the work system, and I already mentioned about this. Everything in work method is prone to failure, but and I mean, human beings have all sorts of situations they might be immersed in, so as not to follow guidelines or principles and be subjected to, pressures outside the organization, like social or family pressures that might impact on that healthcare provider. There's an ever-growing volume of assistance activity. I was listening to Dr. Cañete, and the truth is that throughout the Americas, in every single population in each of our country, I mean, even in the smallest state, Nayarit, my state is very, very small state, and we have serious problems in our health system. So I think that we have the capability of caring for all the population demanding care, and we need to take into consideration how benefit holders have increased that much, and if they hadn't requested service, they are doing now, and we don't have time of caring for all the patients as they would want to, and that bring about stress. And just retaking what one of my peers said, what he said about the situations they're living in their countries, in their health system, is like the respiratory respiratory modules that we have, caring for 40 patients throughout the morning that need quick tests. Then you need to run epidemiological studies, making reports, uploading them to the Sinolab system so they can be registered, delivering the results of quick tests in around 20 minutes, where you be able to print them, give them a medication kit, the prescription, everything. And you're talking about 30, 40 patients a day. So that definitely will generate huge amount of pressure and saturation of our services. So we have this progressive complexity and specialization of processes, and we understand this. We have evolved from a technology standpoint within health systems, and in one way or the other, that makes us have a capability to be able to adapt. And if we're not aware of this, we'll be lagging behind. So before intervening and actually being able to use these technological tools for diagnosis purposes and treatment, we're really lagging behind, and we can be prone to making mistakes. So we need to make an analysis of the root factors, potential root factors of producing adverse effect. What happened in what part of the process, in what part of the working method did this happen, for us to be able to get feedback and know specifically, like you said, be able to raise an adequate report, to be able to work on this and to provide feedback to the organization and try and minimize any 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 similar situations. So of course, it's everybody's responsibility. I mean, if you already pinpointed the risk, you need to attack it, and afterwards, well, work on it and be responsible, be accountable for it. To be able to know exactly where we're acting incorrectly, where we're incurring in any bad practices. So we need to look at our mistakes as areas of opportunity for improvement. We cannot, just acknowledge that a mistake happened and don't do anything. So our collaborators needn't be afraid to notify that they made a mistake. I mean, they report those mistakes that they acknowledge and those analyzed and the ones that we have logged for us to know what to do in those cases. But how many events go unreported from an injection, uh, a procedure in halotherapy, X-ray process, and so on? Those mistakes are not reported. Why? Because we're afraid. Because we're afraid of punishment. We're afraid of being scolded, punished, fined, and that also brings about problems because these mistakes are hidden, and this is some sort of snowball effect that impacts us tremendously in the end, especially when these are made public. And we need to have mechanisms for notification. So what tools should we have in place to be able to notify, report a mistake, a quasi failure? How are we going to notify? How are we going to report this? We need to have a tool that's truthful in place, that's precise, and that really has an impact when reporting, not for just to make it a document. And we need to foster a correct communication with the organization, thus warranting confidentiality of information. That's paramount. Many times, many of the mistakes, I mean, before we know them. I mean, they're known in other areas of the organization or outside the organization, somewhere else in the health sector, and that also hinders, that also damages the image and affects the organization importantly. So I think that the success of health services is linked directly to organizational culture. That is, say, we need to work to improve that organizational culture. Otherwise, we will have to pay a very, very harsh price. I think that clinical security entails the adequate management of risks, working on those risks, tending after those risks, being able to properly avoid them. The capability of analyzing incidents that happen, correct participation of professionals contribute to increasing responsibility, trust, and satisfaction related to health, to patient care. So all of us together, the whole health system, needs to improve patient security. And definitely, like I said at the very beginning, the WHO started acknowledging this part and creating certain tools, some working tools, things like checklists. They made some links, multi-professional links, in terms of patient security, um, checklists during anesthesia process, during labor, medication health, hand washing. So we do have the tools, we have checklists, we have strategies, but oftentimes we set them aside. We tend to set them aside. We don't acknowledge them as such, or there's not a proper follow-up. Many times this doesn't seep into the organization, doesn't go downstream to the organization. And well, definitely, all the information, if it's hidden, if it remains hidden, it won't serve any purpose. So I would like to thank you. Truth of the matter is that this is a very interesting subject, and I think that all of us think of it that way. But we need to work, and we really need to work on this because that's a paradox behind it. Because we know it, we do have the information readily available, we know what the mistakes are, but we still have the adverse effects, and people still paying the price for these mistakes. And right now, from the legal standpoint or punitive standpoint, human rights are even more attentive to everything pertaining to health industry and health sector. So I think that what's ideal be moving forward, having the responsibility, acknowledging mistakes, training people, exerting pressure from the base or the organization from the base of the operational level for this information to be optimum. Because I mean, in many times ones mistakes, and it's even more serious when they come out to to the public, because many times the directors don't even know what's going to happen, and I think that's even more negligent. Why? Because we need to face them, and from the standpoint of prevention and patient security. Now I would like to thank you, and again, it's been it's an honor to have partaken of this diploma course. We didn't have the chance to meet face to face in Mexico City, but I hope we'll see each other again some point in time to be able to take on another diploma course, to be able to be in contact again. Thank you very much, Dr. Lebon. Dr. Alfaro, thank you very much for your participation.
Without doubt, this video that's been developed by this Alliance for Patients, it shows, it proves that this is priority. It can, what's been seen can take us to fatal consequences. We have to work on this on a day-to-day basis to have a decline in risks. Thank you very much, Doctor. Well, right now we're about to start with a closure stage of the day. I'm going to share a few slides because we've seen that all of this aforementioned is so important. Quality in the medical field is so important. It must be permanent. The purpose that we have when we verify, validate quality is to improve constantly the services we offer to patients with the means, resources to achieve this. It's the only way in which we'll be capable of providing the benefits in our country, in Mexico, even though there's progress in the coverage for our population. We expect, or the life expectancy is something that represents a challenge in our country. Obesity, the rates of obesity are high. Di- I mean, there's diabetes as well. I mean, what we've done is not sufficient to tackle the problems. There's situations that limit us when providing services. There's a lot of expenditure from our patients. I mean, they have to spend money out of their pocket amidst the pandemic. We've been more affected by the situation. Our people have. The, I mean, in Mexico, the issue about our population's lifespan is something that we've seen. I mean, we compare the our population's lifespan there with the OCDE, with the economic development entity or body. We've seen the percentages. There's in Mexico that 75.4% versus the 80.7 years. And we're at it's a low level. The death rates, our people are dying, and their conditions or whatever has killed them is something that we could prevent. There's like so many conditions and heart conditions in Mexico. Our populations suffer chronically from these diseases. Now we know that there's been a decline in the consumption in tobacco in our country from 7.6% to 18%. Alcohol consumption has also declined. It's low when compared to other countries. In Mexico, it's 4.4%, and the OECD has 8.9%. I mean, there's also low consumption of fruits and vegetables amongst the adult population and high levels of obesity. That's a warning. Those are flags. I mean, we're not talking just about adults. We're talking about our kids, our children. Our kids are suffering from diabetes type 2. We have to continue walking down that path to narrow gaps. There's a low rate also in children's leukemia. The mortality rate after somebody suffers a stroke or heart attack is pretty high. There's a low level of vaccination with hepatitis V in kids. I mean, it's very complex when these chronic diseases, well, they're affecting our people. They affect the finances of our people. There's also low financial coverage for some people. There's a disparity, the lack of balance. There's a lack of doctors, and there's also an increase in direct payments for this. There's those gaps, as we told you. There's a low expenditure per capita in our country, according to the OCDE. We don't have enough doctors or subjects in the medical field or nurses. We have to be as efficient as possible with our human resources. If we could like relieve the load that the hospitals have, we can progress. But as we all know, and I will not repeat the conceptual definition of quality. We know quality is not static. We know that the concept is universal and the meanings are many, but we are trying to increase in our quality throughout time. For the Joint Commission, I mean, we know that for the Joint Commission, doing things and doing things right is what matters. And the Medical Institute in the US, the IOM, specified, and I quote, that the degrees of healthcare services for the individuals and populations increase the probability of results which are desired, which are, well, correct according to the situations. For Mr. Avedi Zonabedian, and I quote, the type of attention that maximizes the well-being of the patient after having had pondered the balance between the gain or P&L, profit and loss expected, is something that we analyze. There's another author in Mexico that has correlated quality to the following. Now, you have to consider what the patients expect when we speak of quality and the expectations of the service providers. If we speak about continuously improvement of quality, we have to think about the method to manage our quality. Which are the methodologies? Now, and I will stress on one point, we need to focus on the system and how we process this method. With the method in the organization, we need to obtain data. The data must be objective. If it's not, we don't have the basis to evaluate things. We need to develop a set of strategies and schedule. That's why it's so important to have that drafted quality plan with those strategies. We have to make it materialize. We have to systematically implement these plans and strategies. That's a constant process. And only by doing this could we increase quality. And quality is measured. Continuous improvement of quality requires specific continuous attention. Ourselves or work hard for a month, just 1 month. We have to plan it out and be constant, be persistent, find ways to improve things. For this, we need method, and the method and the tools cannot be rigid. It's very important to innovation that's forcefully something that we have to use. And all of this is measured. On a day-to-day basis, we work for our patients. And even if we work with other patients, when we have to go through an evaluation of the services rendered to the beneficiary, how do we evaluate this? We document things correctly, have a log. What's so important about this? We need to be capable of creating objectives branched out into three. Number one, we need to be capable of identifying the opportunities that we have, areas of improvement. We need to draft indicators and be in constant surveillance of those indicators, design and plan the services in advance. We need to know in advance how we're going to do things to achieve the expected quality and results. This is not static. In our day to day operation, we need to obtain feedback. That feedback is object of an assessment. So one of the keynote speakers was asked about how to draft or which are the indicators. How do we supervise indicators? There's process indicators, there's result indicators. What's important about this? We need to know what's the object of the evaluation. Maybe we can't just use general indicators. We need to have a list or select the indicators that need to be measured and evaluated, or else we're going to have different results. Continuous improvement when it comes to quality is something that we must understand as a set of activities that have their differences. Here in the graph, you see the design, cycles of improvement, and monitoring. It's a cycle. And since it's cyclic, we can use this for the evaluation. The kickoff point in cycles of improvement as an activity, we have to identify the risks and problems. What for? To find the opportunity to improve our services. What's the immediate objective? Let's avoid risk. Let's solve problems. Let's have a reaction and action. If there's a problem and we're facing the problem, let's solve it. Action, measures in place. We don't want that same problem to happen again. We have to profit from everything we have. Something that's important when it comes to quality control at hospitals is the bedrock of the quality control plan leads us to have a list of indicators, incidents, risks correlatable to the conditions of the patient. If the patient has an adverse scenario, which other elements can we correlate to that situation? That data will allow us to understand the problems that we have in our hospitals. So we can start with all action to eliminate what hinders. As I told you, we need to be constantly monitoring indicators of the processes that we design to control quality, to go through that self-verification. We need to also compare ourselves. There should be a peer review. There should be like an internal evaluation, an external evaluation regarding us and the services that are provided in the hospital. In contrast, what's happening amongst all our institutions in our hospitals. Why? Because that allows us to interact with other institutions that are focused on health, to measure how we're doing, to measure the areas. In the design, we need to be capable of identifying the needs and expectations of stakeholders, whether they're users or relatives, plan the services that are going to be offered, and identify parameters and the results. What follows? What's next? To achieve the best results, we have to follow the process. Of course, we need engaged directors. We need the structure totally engaged with a strategy, with a proper mission, the reason, the essence of the institutes that we're with. I mean, we need to express clearly our commitments to improve continuously. This is translated into measurable objectives, plans of action to exercise our duty. There's different ways, there's different systems to manage quality. Some systems are centered on the patient. We're talking about standardizing multidisciplinary processes with a systemic focus to have a decline in the variability of the attention or services so we can guarantee quality. There's other systems that are centered in management. There's standardized processes in compliance with laws and regulations, in compliance with the institutional law or internal law, to continuously focus on the quality of the services that we provide. Who is responsible for quality? We're all responsible. Quality is everyone's responsibility. It's not one person's responsibility. There's interaction amongst staff, all, all staff and all the stakeholders in the system. It's important for those, I mean, those who are responsible are the leaders, top management, and that has to cascade, roll down to all the levels of the structure. That's part of the culture that complies with quality, safety. We have to be on board with a quality level to achieve our security because it's a national issue. Now, it's very important for us to systemically have our focus. Sometimes, at hospitals, in each department, they analyze their processes and their services, but we're all correlated. All areas in a hospital are correlated. If a patient comes to the emergency unit, but he comes towards emergency, but we don't have the right communication or correlation to the people in the MRI area, and the patient is suffering a kidney failure, and he just needs the process or the solution, and if we don't have the protocols in place and the ways in or that we need amongst our areas to communicate properly, we're not going to be capable of providing the full dimension that the patient needs. In our focus, we need to understand and manage the process, the protocols systemically, so we can finally achieve a total efficiency in our institutions. Hospitals which are under an accreditation have to be under the standard. It's systematic. All areas are involved. That makes our operation robust. We're analytical when it comes to our system. We need to have the right guidance to identify each process, design them, draft them, pinpoint the key indicators. What are we going to work with to go through the proper evaluation of what we're doing and give feedback to our institutions, to our hospitals? In the healthcare system, we have a response mechanism. We need to satisfy the needs of our population, of our citizens when providing services. This is fundamental. When we speak about the quality of medical services, it's important to manage properly the services. It's extremely important. We've discussed this in this session. The medical services provided have to be in compliance with the laws and regulations that are in effect. There's standards, but in which jurisdiction or which area are we providing the service? We have to comply with laws, regulations, all the provisions. The healthcare professionals have to be skilled enough, under accreditations, competent. They need to be experts in their field. For the services that they're going to be providing. This is part of the performance, the timely performance, the correct performance under ethics. That's quality. You need to execute your actions under the quality control without having the need of a third party supervising your actions. How am I aware of this? Awareness of what our professional development to do and execute the tasks in our field and in our scope. I need to update myself and I have to work under the right level in compliance with ethic. I need no one to be breathing down my neck to make me do the things right. So let's take action timely, execute in your performance. Here we have all the guidelines, there's policies, we have medical literature, documentation of it in all the fields, dentistry, odontology, and we have data. We have the scientific backup for clinical practice. We have general documentation in the medical field that's and we work based on this from documentation that's national or international. When it comes to technology, the progress when it comes to technology is faster. We need to know which are the technological material resources that we can have, how they work, how does technology work, what are the using it, what can have an impact on the patient, what could happen. So we have to understand thoroughly and have preventive measures in place to counteract that. Now, today, the research field, investigation, research opens the door. It opens the threshold to really find new ways of providing new services for our patients. We need to progress when we're drafting public policies, specifically in like the healthcare field, to be capable of acting in trying to prevent further situations. Now, our medical practitioners are in continuous development as professionals. We have to improve always as professionals. We need to offer quality services and improve it constantly. That has an important impact when it comes to the costs. We need to analyze the costs correlated to offering something that's of low quality or poor quality. How much does a lawsuit cost? How much does that cost? I mean, that's impacting our budget or our finances as institutions. That's why, I mean, we could use like the money used in a lawsuit to go through another procurement process to buy medication, to hire more staff, more members. I mean, in Mexico, the healthcare system in Mexico, in the current administration or Cuarta Transformación, they're trying to find structural changes under the principles of quality, fairness, and there's legal or changes or in the structure. We're working for the first year, first level of attention in the medical in the hospital network. I mean, there's fields such as areas of specialties in the medical fields. We're focusing on the first level of attention, and that the general practice or first contact. We need the proper doctors in place so we can fight all the chronic diseases and other conditions that lead us to complications. This is the model. Primary attention scheme here. We're centered on a patient. We need to prevent, detect, and timely treat the subject in place. Those are the models for the first level of service. And this is something of our full operation. We need to aid our patients and prevent, educate, and foster education. We need to continue developing. We need to continue growing. I mean, we need to provide the proper services in our centers, like screen, send the people to in reference to other hospitals, and have the centers, in our hospitals that way. It's also important to rethink about our development as professionals in the exercise of our profession and our duties. We need to be capable of having more talent or more people under constant development with workshops, seminars to update the knowledge of the doctors that we work with. It's like priority. We need to standardize the offer of services that we have in all our units. It should be standard in coverage. We need to have the right elements at work in a team to finally see results of great value. I mean, systemically, we can see the benefits and the effects when we have the proper performance of the systems and processes in place. This is why we can say we are safe, reliable organizations that work for society, always, always in the fight to achieve that excellence. The value is acknowledged in the structure of things. I mean, we have reports in which we have the incidents, like a matrix of incidents that are correlated to what happens. I mean, with the safety of our patient, what happens if we commit a mistake and the patient is affected? Okay, we fall, we get up. It's like if somebody has an incident, or it's like if you fall, no, you don't want somebody else around to see you fall. You fall, you get up fast. But if a, a peer, a colleague commits a mistake, and a colleague in the medical field falls, that could happen to us. We can also fall. And it's been proven that incidents repeat themselves in the same hospitals. The same mistakes are committed at a global scale. It's not just happening in one place, in one institute. So we have to constantly study and have the preventive measures in place too in our hospitals. We need to include the indicators to evaluate the long, mid, short-term risks. These indicators help us measure our results. We need to develop and use the instruments that enable us to see what we're doing and with what level, at what level. I mean, what are we giving our patients, the relatives? We as service providers in the medical field, as doctors, might have an understanding of things, but maybe the administrator has another way of understanding the same situation. And at the end, if you have a patient undergo surgery, we want everything to be right at the end of it. Maybe the managing stakeholder would want simply the patient to go through that surgery without further complexity. I mean, we have, and the administration wants the resources to be used correctly. What would the patient want? The patient would not like to go through more expenditure and have the positive results. I mean, each party involved in our processes, I mean, has different expectations. I mean, everybody expects something different. The relatives of the patient expect something different. We have to study the level of satisfaction as well. I mean, we have to understand the customer satisfaction there in the medical field and the perception that people have and how reliable they think our institutions are. We have to obtain information from the users or survey or user to obtain the data, schedule the feedback, obtain the data, and know exactly what's happening in our hospitals. So our hospitals should be seen as institutions that are trustworthy, reliable to begin with and to end. I'll tell you that Joseph M. Puran mentioned that the improvement of quality must be exercised continuously at a steady revolutionary pace. Thank you very much. Thank you so much, Ms. Dubon. Thank you, Doctor, for moderating the panel that has come to its closure. Thank you for all the keynote speakers. You've been magnificent. Thank you for sharing your presentations. You're based on your experience. You shared your experience to us. It's happened today. Thank you for sharing. You improve our actions and our activities. We thank our students. We thank the participants. In general, thank you for having an interest in the subject of quality. You followed us in social media. Thank you for following us in different platforms. It's clear to us that quality and continuous improvement is part of the process will lead us, that control of quality leads us to improve our actions. this conference is contributing to improve and train all of those who have an interest in such an important subject. And on behalf of our director, our president, Ms. Daisy Corrales, we thank you for being here. And I only have to tell you now that tomorrow will start at 10 a.m. Today we're in closure. We're going to be talking about managerial bioethical issues in our field. With tomorrow's conference, we're going to finish with our virtual or remote workshop. Thank you so much for being present. See you soon.